Hello, good morning. Good morning, can you hear me?
Yes, I can hear you.
साढ़े नौ बजे नहीं तो 10 बजे का है Okay. सर हाँ
A very warm and pleasant good morning to one and all. I am Darshita Surori, Vice President of Optometry Students Association. It takes immense pleasure for me to welcome you all and share this delightful
दर्शिता जी
morning
1 मिनट.
with you.
दर्शिता जी 1 मिनट. 1 मिनट.
So, we are beginning with session one, Orthotics and Vision Therapy.
दर्श
I am
दर्शिता
glad
जी कैन यू.
to
दर्शिता
respectfully
जी.
and cordially welcome Professor Rohit Saxena, currently the chairperson of Bachelor of Optometry in AIMS. Yes, pursued his PhD from AIMS New Delhi and is currently serving as the Professor of Ophthalmology in Dr. Api Center of Ophthalmic Sciences. He has been awarded the certificate of esteemed resource teacher and has been taking care of us with full dedication and enthusiasm. He has published greater than 133 publications and has received more than 30 awards for his research and academic contribution. Over to you, sir. We welcome you.
Thank you, Dashita. Can I start my screen share? The tech team had some questions.
Yes, sir, you can start.
Thank you. My slides are visible?
Yes, sir.
Thank you. So, I'll be talking about prevention and management of childhood myopia, a very important issue that is now coming up, which needs attention from all eye care workers. So, the first question actually is that over the past 10 years, especially in India, we're trying to increase awareness because many feel that it's not really such a big problem. But this publication in ophthalmology actually in 2016 actually woke up everybody because it predicted that 50% of the world's population is going to become myopic by 2050, and of them 10% would actually be high myopes with their associated problems that we see in patients of high myopia, that is glaucoma, retinal detachment, retinal degenerative changes, and of course increased risk of cataract. So these are major issues that require attention, and the key is to prevent this epidemic from happening. Again, while internationally, particularly in the eastern part of the world, that is East Asia, Singapore, Taiwan, Japan, it has been proven to be a major cause for concern and is actually now termed an epidemic. But in India, really, the concern was not so much, and many people did not actually believe that it's a major problem in India. So one of our studies, we found the prevalence to be about 13%, but again, it didn't sound so bad as compared to 50 to 80% in East Asia. But the key thing was the cumulative incidence, which was 3.3, which essentially means that over a decade of an increasing incidence of 3%, we would land up having a prevalence of close to 30%. So we know that we are slowly uh, and surely reaching towards the problems that are there in Southeast Asia. So the other issue was that is it actually increasing in India? Now the question was that while current prevalence rates are modest, and is it that we are predicting what is being predicted for the world? So is it true for India also? So this was a meta-analysis of last 4 decades that we did of all the published literature in India. So we meta-analyzed all of that, and the outcome was that currently the prevalence is 8.5% in urban India and 6.1% in rural India. But the key problem was that this has in rural India shown an increase of from 4.6% to 6.8% over the last decade, showing that even rural India is now beginning to come at par with urban India, with probably the associated issues like increasing near activity, increasing tech use of tabs, phones, laptops, and all those associated gadgets that are now known to increase the possibility of myopia. So the major risk factors we know are a low hyperope than age normal. So up to 2 to 3 years, we know that children have six up to can have up to 6 diopters of hyperopia, which slowly decreases with age. But a child by 6 years of age, if he has a hyperopia which is less than 0.75, is a risk factor for developing myopia in the next few years. Girls are more at risk for various reasons. We know that in urban areas, myopia is definitely more prevalent, possibly because of a lack of outdoor activity, lack of spaces, constricted living spaces, and a major penetration of tabs and phones. Higher educational levels are known to have association with myopia. In India, we have multiple studies now showing that private schools are more at prone, again, possibly because of the high pressure academic environment, the higher socioeconomic status, and of course, one of the key factors is parental myopia, which is 3 times at risk if both the parents are myopic. The other risk factor is the visual environment. So, long hours of continuous close distance reading near activity is a very high risk environment for development of myopia. There are two possible ideas or hypotheses behind it. One is the use of continuous accommodation, and the other is a light dopamine hypothesis, and that going outdoors increased amount of time outdoors releases dopamine, which is actually preventive towards myopia. So indoor activity means reduced dopamine levels, means increased risk of myopia. So this is the other thing. The next important thing for all of us is the role of binocular vision anomalies and accommodative lag. So these children are known to have esophorias and accommodative lag for near, a reduced accommodative facility, and an enhanced accommodative convergence. So now these are issues which are seen to happen in these children, although we are not very sure that they are a cause or a consequence of the myopic problem that these children have. So again, it's very important for us to be aware so that we can check on children who have these issues, making them prone to develop myopia in later ages or as they grow older. And of course, like I said, outdoor activity is the single most important protective factor for myopia. And studies have shown that more than 14 hours a week of outdoor presence. So it's not just activity. I mean, it's not necessarily activity, it is just presence. So you could just be standing outdoors in the light, and that itself is protective. So a total cumulative 14 hours a week is enough to protect or reduce the risk of myopia. So multiple ways in which it is supposed to act: increased brightness causing release of dopamine, or of course a more uniform zero dioptric field. So if you look into the infinity, your eye is not working at all, and in indoor constricted spaces, the eye is constantly, even slightly, is accommodating at all times. So that may be a stimulus for the development of myopia. Now, how do we prevent? So the first thing is to prevent the onset or primary prevention. You identify the pre-myopic child, and a pre-myopic child would be one who has low hyperopia. We just discussed that. One or both parents are myopic, spends less time outdoors, has increased near activity related to reading, writing, tabs, phones, has some binocular vision disorders like an accommodative lag or a higher AC by ratio. So these are the pre-myopic children. While in Singapore and in some areas of East Asia, studies have already started on the preventive role of atropine in pre-myopic child. But in India, it is really not at the moment necessary. But the key interventions we can do is increase awareness among parents, do a risk factor modulation. So the APOS, in association with the American Optometry Association and American Academy of Ophthalmology, has come out with the 20-20-20 rule, which means that after 20 minutes of close or near work, take a 20-second break and look for 20 feet into the distance. The best thing you can tell our parents is that, or the children, is that after about 20 minutes to half an hour, ask the child to get up from his table, go to a window, drink a glass of water, just look into the distance or out of the window for some time and then get back to his work. So this will give that adequate relaxation for the eyes, and of course increase outdoor activity. So presence outdoors is extremely essential for these children. How do we prevent progression? That is the key thing. Once the child is myopic, how would we prevent their progression to progress into a high myope? So the key areas of intervention are refractive and pharmacological. The refractive is under correction of options are under correction of myopia, spectacles, soft contact lenses, orthokeratology, and progressive ad lenses. And pharmacologically, really the only treatment available at the moment is atropine. We'll just run through some of these quickly. Spectacles or contact lenses, at the moment, there is no evidence that under or optimal correction of single vision glasses or contact lenses has any effective progression, and that includes both soft contact lenses and RGP lenses. There is no difference in outcomes after these children wear or do not wear these lenses. The key work that has gone on is the role of peripheral hyperopic defocus. So while we give glasses which give optimal correction for near and the child has good quality central visual acuity, but these glasses have a peripheral hyperopic defocus, and in their periphery they're actually giving a hyperopic stimulus. So this is considered to be one of the factors that is causing myopic progression, and myopic defocus are the now concepts that are being building up, and a peripheral ad approach is now considered as important for preventing progression of myopia. The other thing is accommodative lag. So the role of bifocals and basin prisms is important. So you can see that you can see these children do have a definite accommodative lag, and therefore that again may be responsible for the risk of myopic stimulus. So the interventions possible are bifocal prismatic ad lenses, which have been shown to significantly reduce myopic progression over single vision lenses. Soft multifocal contact lenses are probably the single most welcome and accepted intervention. The first FDA approved intervention for myopia, the Cooper Vision MESAT lenses, and they have shown to
हाँ
definitely
got it.
decrease
ठीक है
myopic
ठीक है.
progression by almost 35%. Orthokeratology and another intervention, although from an Indian setting it has not found to be very popular because of the risks of keratitis and the discomfort of wearing a lens overnight, but it also corrects glasses for distance in the morning, so the child may actually be cosmetically better also, and they have shown to have a reduction of almost 45% in the myopic progression. Just a bit on the pharmacological intervention. Other than atropine, no intervention is found to be successful. Among the earliest studies were the ATOM studies from Singapore, which have shown the effect of low dose atropine. They have worked on 0.01%. From Hong Kong, another group has worked on 0.05 and said that 0.05 may be a better concentration to work on with minimal or virtually nil side effects. We recently published our work from India. It was a multi-century trial which involved 3 centers, including ours, and we showed that 0.01% atropine was significantly beneficial in preventing progression or reducing progression in children with myopia. So this is a table I leave you with. A whole lot of options are now available for preventing progression of myopia. And remember, time outdoors spent itself is a significant impact as far as preventing progression is concerned. And this is a wide range of atropine because it varies from 0.01% to 1%, and therefore its efficacy is variable. But you have other things which also are very effective, like prismatic bifocal lenses, progressive ad lenses, and peripheral ad lenses. And of course, finally, if nothing, once the vision is stable, you could think in terms of refractive surgery. So where are we? Prevent onset by increasing awareness, intervene early, teach good eye care habits, encourage outdoor sports activities, avoid or minimize exposure to handheld devices and computer games and television, take frequent eye breaks. In fact, if possible, read in natural light next to the window, and maintain good reading distances. Preventing progression, we know outdoor activity works in preventing progression. Atropine drops, soft contact lenses of various ways, particularly peripheral ads, and of course orthokeratology. And I leave you with this image from Singapore, which is one of the major epidemic areas where a lot of work on atropine and overall prevention of myopia progression is concerned. They have this slogan, to keep myopia away, go outdoors and play. So this is one of the things that we must encourage our children to do. Thank you very much. Sumit, I think you are mute. We can't hear you.
Sumit, your voice is not coming properly.
Hello, Vikas. Welcome.
Good morning, sir. Nice to see you, and it was very informative talk.
Thank you. Thank you,
Excellent.
Vikas.
I think you are a genius person, and
Mhm.
it is we are privileged to hear you.
Thank you.
That's a
Thank you
great
very
work,
much,
sir.
Vikas. It's a pleasure to see you also. And thanks to OSA, we get to meet once a year. Unfortunately, this time it has to be virtual, but we hope that as things get better, we can have you come across to RP Center sometime. I'm sure our children would gain so much from you.
So, that's my pleasure. I would like to come and see you also.
Sure.
Great.
So there's something wrong with your mic. Either you remove the mic and then use the computer, the laptop audio, because if you're on a desktop, then your mic has some issues.
Hello.
Yes,
Yes,
we can
we
hear
can
you
hear
now.
you now. Thank you so much, sir. Over to you, sir.
Uh, Good morning. Now we
Vikas,
can
just
hear
try
you.
your
Yes.
setting. Yeah.
Thank you so much, Rohit sir, for your wonderful talk. Now I request to Mr. Vikas Srivastav. I am extremely honored to have this opportunity to address Mr. Vikas Srivastav, currently serving as Assistant Professor and HOD of Galgotia University. He has professional experience of 21 years, not only in optometry teaching, but also in the clinical practice. His area of expertise in progressive myopia, positive factors, and clinical method to control it. He has published various paper publications. Over to you, sir.
Thank you. Can I share my slide?
Yes, sir.
Okay. Sumit, is it visible now?
Yeah, it is visible. Just make full screen.
Okay. Full screen. I think.
Uh, it's that link in the bottom. Just make it at the bottom right. Yeah, just click that.
Okay. Great.
Great.
Thanks for the help. Welcome, everybody. And it's my pleasure and honor to be here and talk in front of such a knowledgeable and dignified people. And it is nothing more to add once Rohit sir has already explained so much and he has gone up to the depth. He's a pioneer in our field and I appreciate his work. I'm just trying to add on to that is like our experiment in this field of progressive myopia. What we are doing actually, we are doing first-hand experience of doing this trial on patients, and we are having some data to share with you. So we'll just try to go step by step. I would like to make things more and more simple so that even a basics are clear to everybody. So when we talk about progressive myopia and myopia, we are trying from basic like ABC so that everybody can understand. I'm Vikas. I'm a HOD Associate Professor in Calcutta University. But first of all, I'm a student and Amsonian. And I appreciate Rohit sir and all my teachers and my Amsonians and everybody who has made me up to that level. Thanks, and it's an honor to be here. Epidemiologically study on a national survey when we talk about 2021 and 2019, there is a sharp increase of myopia 17% in last 20 years. So this increase is very alarming and it is an urgent need of an hour to find out factor causing it and how to control it. So today we see a lot of more progressive myopias in 20. Previously, it used to be like people get myopia with the problems and with those who have genetics. But now we see those even who don't have a genetics also, like parents don't have a myopic problems, but the kids have. So those fast increases of 17% in 20 years doesn't justify that it is all because of genetics. We we try to find out what are the other factors which are associated with these myopia. Myopia is more common in a subjects who are doing near work for more than at a distance of 30 centimeters for more than 5 hours per day, and they are on our statistics we observe that those people are 2 times more myopic compared to those who are not having that much of near work and who are not having 5 hours of average time on near work and desk work. Second things we studied from our literature review is that myopic is more common in family with low income group, and myopia is more common in people with high education. So we try to do our experiment research first hand primary data experience whether these things are exactly following in our study also or not. We try to study what is basics I told you, like conditions of eye in which the parallel ray of light is focused in front of retina when accommodation is relaxed. That condition is called myopia or short-sightedness. Reason can be eyeball size is too long, optics eyes of eye is too strong. So in both these conditions, the light is focused in front of retina and we use concave lenses or minus lenses to focus it. There are other associated factors like increase in refractive index, forward movement of optical the components like the movement of a lens or cornea, keratoconus. So all those conditions associate together and bring an optics which is too strong and then light is focused in front and that is called myopia. When we talk about progressive myopia is a condition. Progressive myopia is the condition in which the refractive error of eye continues to increase. We considered all those cases who are showing increase of 0.75 and more dioptric refractive error within an year's time. So general tendency we try to associate with them and try to find out that is like slight change in axial length if we study it for longer duration for 10 years. But these are major changes which is studied and identified in a long-term study, like increase in axial length, increase in corneal curvature, and increase in accommodation. So when we see these are becoming more and more curved and axial length is increasing and tendency to use more and more accommodation like pseudomyopia or tendency to use more accommodation in case of hypermetropia in which latent hypermetropia is controlled by overuse of accommodation. So all these factors help and associate together to produce a progressive myopia. That is tendency to change or increase the dioptric power of eye 0.75 and more per year. Factors responsible for progressive myopia, as Rohit sir has already explained, excessive near work, and in our literature study, we have already seen that low income group probably they have a deficiency of balanced diet, which leads to this factor. Genetics, one of the most common factor. We all know if there is a genetically parents, both of them are having myopic, there is very high probability, like 10 times higher probability of those kids getting myopic. Poor light and illumination condition in which the student is working or or the subject is working. There are certain pathological conditions which aggravate myopia. So numerous studies show that after sustained near work, subjects become more and more myopic. Theories explaining the factors causing progressive myopia. When we try to find out what are the theories and logic behind, we realized that theory of peripheral refraction states that due to oblong shape of eyeball, peripheral rays do not get focused at the retina. This is like when we see the optics of eye and we see all the rays which are coming to the peripheral side focused slightly outside the retina, and then they become uh, uh, they in an oblong shape, and then they tend to be more hyperopic. So when the peripheral radiations become more hyperopic, eye tend to adjust itself by stretching, elongating itself, and that causes continuous pressure of increasing and enlargement of eyeball. And this is like theory of peripheral refraction, which suggested that all those who are having high myopia, they tend to have more and more peripheral refraction distortion, and this peripheral refraction distortion, which is hyperopic, tend to stretch eyeball and cause stretching. This stretching causes continuous increase in eyeball size and myopia. The second theory, which states that why a myopic tend to go into a progressive myopia, states that myopia is corrected by a concave lenses. Concave lenses are focused for distance work. So whenever that subject is trying to read for the near work, he is using an accommodation. This accommodation is induced by continuous pressure of ciliary muscles, and this stress causes stress on eyeball and elongation of eyeball. So both these theories correlate that those people who are doing near work more, they are tend to stress more on eyeball, and when the stress on eyeball is beyond a certain limit, it causes enlargement of eyeball, and that is what we have studied from a long-term study. Like if we study these patients for 10 years, we realize that axial length is being increased in these patients who are having progressive myopia. So theories are almost established and accepted by long-term studies. Theories to theories to justify an effective method of controlling progressive myopia. Use of progressive glasses. Like we have clearly understood, it is an accommodation and it is stress on the peripheral side. So what we try to do is that we try to relax these accommodations. So there are three main methods on which we try to focus and relax accommodation. First is use of progressive glasses. Whenever we use progressive glasses, demand for accommodation for near work is reduced. So in that condition, stress on ciliary muscles is reduced, and then stress on eyeball is reduced. Second part, we use atom treatment theory, in which we use 0.01% atropine, and that is prescribed to the patient once in a day. So what we realize, this cycloplegic causes relaxation of accommodation of a patient. This is a parasympathetic effect, causes relaxation of muscles, and this relaxation and dilation help this relaxation tend to reduce the stress on eyeball. There is another factor, that is like the release of dopamine and synthesis of glycosamine glycan in sclera reduces the elongation of axial length also. So we realize this atropine does affect on two states, on ciliary muscles and reducing stress, and on a sclera and reducing the tendency to stretch scleral size. Then the third part which we stressed on is the relaxation therapy. We tried to explain them how to relax, like giving them 20-20 rules, like they should follow after every 20 minutes. Go and relax, wash your eyes, relax your eyes, go at least look and at the far distance. Or I suggested few of them, like if it is possible, keep your reading desk and working desk in such a way that whenever you are working, your you are not facing the wall, you are actually facing window side. So whenever you want to relax, instead of working on laptop or computer or book, you can see far and relax your eyes faster. So 20-20 rules we explain to all those patients in our subject study, and we explain them what you have to do in relaxation, like wash your eyes after 20 minutes, keep your sitting desk in such a way that your sitting arrangement make you do work, and at the same time you can change your gaze and see far and relax your eyes. So all these steps we teach to our subjects, and then we have like we do the study in such a way that there is a standard group also. So our research problem, whenever started our research, we tried to focus what our research problem, like to find out correlation between progression of myopia, like progressive myopia, and factors which are causing it, like excessive near work, education level, and professional level. We tried to correlate it. Those who are having slightly higher degrees, we consider them that they have been working hard on the near work. So we subjectively associated those subjects who are having higher qualification and those subjects who have in a questionnaire explained how many hours they study in a day, like those who are preparing for IAS exams and those who are doing medical studies and those who are doing MDs and MBBS. So we consider those and we studied and we asked them what is their qualification and then what is the number of hours they study in a questionnaire form. Then we have a family income group and we try to generalize what is a family income, and we try to identify whether father and mother, any of them, or in their relationship with the genetic history, they have brothers and sisters, they have myopic glasses. So we try to understand their genetics based on questionnaire. We try to understand this preliminary factors which we can say these are the factors which are responsible for causing myopia by taking questionnaires and asking them these questionnaires and then correlating it. Then the second part is finding out the best correlation between progression of myopia and most effective method to control it. We tried our study subject group prescribing progressive glasses, prescribing 0.01% atropine OD, and a relaxation therapy 2020, which I explained just now. Hypothesis: when we tried this research, we made some hypothesis like we would be checking this. Progression of myopia is directly proportional to number of hours of near work to, daily, and then family income related to a balanced diet and the genetics. So we tried progressive myopia is directly proportional to these three factors. Then we tried to find out most effective method to control progressive myopia. So we have a standard group and we have our study group. So all those who are in study group, they are provided with progressive glasses. They are provided with atropine 0.1% OD eye drop, and they are provided with steps to go for a balanced diet, and they are explained 2020 rules of relaxation. And whenever they come for follow-up after every 6 months or in between if they have complications, we try to ask them whether they are following it and how they are following it. And in every visit we try to explain it again so that they understand the importance and they follow. And in the meantime we have like questionnaire on phone calls in every month to just understand that they are following these relaxation thoroughly or not. So most of the subjects who are following these rules 2020, we consider those who realize that they are not following, we remove those. So we have only pure data who have followed this treatment plan effectively. Research methodology by comparing myopic progression or changes in dioptric power in two groups. So we studied two groups and we find out like what is the rate of change of dioptric power. So we realize that whether there is an increase in progression of myopia or whether there is a control in progression of myopia. Regression analysis, a study of impact factor. Regression analysis is like factors correlated to causing progressive myopia. So from for that factor, we picked up questionnaires and we picked up their previous prescription. So we can correlate that these pupils can be considered under the progressive myopia, and from the questionnaire we try to find out these are our subjects and then the factors we identified to correlate them. Prospective analysis. Our study was based on T study method, like a study of effect of treatment plan on myopic progression by comparing a study group with a standard group. Our study group is prescribed progressive glasses, atropine 0.1%, and relaxation therapy, and explain what diet, matlab they should have a balanced diet. So those things are our counseling part. A study group has been explained all these things, and a standard group is not explain this, but they are prescribed glasses and observe the changes which are observed after every 6 months between these two groups. So they have been observed after every 6 months for 2 years. Till now we have studied them. In between, we do follow up on calls to understand whether they are following the relaxation therapy properly. Every monthly phone call has been recorded. Sampling criteria. We studied 200 eyes, that means we had studied 100 subjects, and they have been examined thoroughly for the characteristics of progressive myopia, and all those who are having changes of more than 0.75 diopter in myopia have been kept as a progressive myopia subjects, and they are studied. Inclusion criteria में we picked up all those subjects who were having 20 plus minus 5 years. We generally consider that people that the kids grow, and then there is the eyeball size is stable at the age of 10 years. So we consider a still considered 5 year gap, like the developmental growth is not the factor which is causing progressive myopia. So we picked up all those subjects who were having age group from 15 to 25, because we consider from 15 to 25 there is no further axial length growth because of development of body. Matlab his height is already reached to final stage, and his like size of eyeball is not increasing because of the increase in body size. So it is totally correlated to effect of our study, like effect of stress and effect of accommodation and effect of peripheral radiation. So we understand that all other factors which were affecting are tried to be affect as minimum as possible. So our subjects were from 15 years to 25 years of age, and a refractive year which we filtered for them, because we consider these are the study group which were more interested and which were having ch- chances of progressive myopia. So refractive error from -3 to -9 diopter were considered in this study. Their retinal correspondence, like their retina is normal, and macula is functioning normal, and then there is no disease like diabetic retinopathy, leakage, hemorrhage, or there is any myopic hemorrhage, leakage. So myopic effect of retinal hemorrhages are not there. So their retina was normal, and then both eyes were having normal retinal correspondence, like macula is functioning and there is no squint and there is no abnormal retinal correspondence. So other ocular structure like cornea is transparent, normal, and then there's not keratoconus, and then there's all other things which are slightly different from normal. They have been segregated, and systemic disease condition has been segregated. So all these subject group or all these standard group, they were healthy and they were within this slot group. Exclusion may we remove those who are having visual acuity less than 6/9, and all those who are having squint tropias, whether they are exotropias or isotropias, they have been removed. All those who are having pathological conditions like diabetic retinopathy, or like different kind of uh, जो complications हैं, like iritis है and other conjunctivitis है, any other conditions which is which we can think that they can dilute the clarity of subject study. So pathological conditions are removed. All those who are having mental abnormalities, like those who cannot clearly explain things, mentally disturbed people, we remove them from this category of study. Our study goes in such a way that our standard group was prescribed glasses and uh, was not explained the treatment procedure of 2020 rules, and was not explained, was not provided a progressive glasses, was not given an eye drop of 0.1% atropine OD. Instead, when we picked up our study group, we take their consent and we prescribe them progressive glasses. We prescribe them atropine 0.1% eye drop. we explain them 20-20 rules for relaxation of exercise, and in this part we explain them what is the balanced diet they should have. So in that way, we picked up a study group and in a broadly those people who are following our direction of treatment. So data collection was retrospective to find out the factors causing this myopia. Retrospectively, we try to find out factors causing. Once that our inclusive group is identified, we try to find out how many hours they work on near work, and from the questionnaire we filled up, we correlate it with their educational status also. Then we picked up the income group, and we considered that those who are having low income group can can have a problem in arranging the balanced diet. So we picked up that way, and then we considered a very high income group also, and we see that they don't have any problem in arranging the balanced diet. So we at least arrange those in income group, and we try to study. Genetics also, we try to find out whether father and mothers are having myopia, and even brothers and sisters, siblings are also having myopia. So if any of these three categories are having myopia, we correlate them with the genetically related. So prospective study in which we were trying the treatment method, and we were trying to find out what is the effectiveness of the treatment. We tried to provide them refractive error. Whenever we provide them glasses for refractive error, we try to give them glasses by giving prescribing glasses with fogging test. So we don't over prescribe them minus glasses, and we don't try to we provide minimum uh, by fogging method. We provided them plus power if it is required. It is all myopic, so we prescribe them. We don't over prescribe them any of them the myopic glasses. Then in that condition, we also provide them near adjustment by progressive glasses. We provide them low concentration of atropine 0.01% and once a day, and then we provide them relaxation therapy. This is how we categorize our two data collection research procedure. Like we have done few of these examinations. Patient's personal data is to identify, and then that data tells us factors causing myopia. Then patient's data for present status and correlation of prescription like visual acuity, keratometer, subjective refraction, best corrected visual acuity with minimum minus power, and binocular function test of simultaneous macular perception, fusion, Stroop slit lamp examination, fundus examination, axial length assessment, and then recording all these findings every 6 monthly for 2 years. This is our format which we used to assess our data, and we this is the examination format. There are 2 pages for examination format. So in this examination format, we did all the examinations, and we find out what are the changes at every 6 months. The same way we have a questionnaire, and we questionnaire them, and we recorded them also. So we analyze our data. Data is analyzed statistically, and by using a T method, T research method, in which we have a study group and we have a standard group, and we don't try to control all other factors. Like if it is a 2 years period and it is a human being, we cannot control all the factors which are going to affect these people within these 2 years. So we have two study group in which all external factors are equally affecting both of them, except the treatment plan which we explain to one category, and the no treatment plan of relaxation or atropine or progressive myopia, progressive glasses to the other group. So that is the only difference we induce between these two groups, and we try to analyze the result. So a systematically organized data is led to a conclusive information, like significant effect of various factors are recognized, correlation between various factors were studied, difference between a study group and a standard group is evaluated. So this is our finding from the research, like induction of progressive myopia is due to near work. When we try to identify those people who are studying for more than 5 hours a day, we realize that it is more than 65% people who are having work for more than 5 hours a day or having progressive myopia, compared to those who are studying less than 5 hours, they were quite less, and approximately 40% of them. When we talked about family income group, this was quite different from our expectation. Initially, we were expecting that those who are having low income group would be having progressive myopia. But in our study, we realized that low income or income is quite unrelated to induction of progressive myopia. Instead, what I realized is that, like at this stage, there is no deficiency of alternative to choose from a healthy balanced diet. So even those who are having low income group were having capacity to organize balanced diet. Instead, what I realize is that those who are having a high income group were going for a more fast food kind. So instead of picking up a healthy diet, they were picking up a diet which is quite lubricative but less balanced. So it is like in our study we realized that the significance is not much. Family income significance is not much. It is almost like 52% and 48% difference. So significance is not much, but it is identified that being a low income group doesn't says that it will have progressive myopia. Induction of progressive myopia due to genetics, that is closely correlated. Those who are genetically related, they are having 62% chances of having progressive myopia. Control of progressive myopia due to treatment plan. We realized that all our study group in which we tried to use progressive myopia control program, they responded better, and their progression is controlled and quite regulated. They don't progress that much. So in our study group, they responded and they controlled better way as compared to our standard group in which it is not explained. From retrospective study analysis, it is found that these factors play a vital role in inducing progressive myopia, number of hours of near work, genetics. Definitely, family income does not play a significant role in our study group, which we study. From prospective study, like treatment plan, we find out that the study group followed the recommended diet treatment, have remarkable improvement in controlling progression of myopia. Conclusion, like if we change our lifestyle and if we avoid doing excess near work, or if we plan our near work in such a way that get relaxation as well as relaxation after every 2022 formula, and we have a balanced diet and we have a proper treatment and diagnostic system, and then we control it by using atropine also, so we can reduce the growth of progressive myopia. Conclusion was subject accepted based on fogging helped to reduce the stress on accommodation. Like when we prescribe glasses, we use fogging technique that also helped us to regulate the stress on accommodation. Our progressive addition glasses also helps to reduce the stress on accommodation, and in certain condition when there was very high myopia and if the patient is using contact lenses, we ask them to wear contact lenses for distance, and that helped us to control the peripheral ray impact of inducing stress on eyeball. So they were using contact lenses for distance and zero power for in a progressive glasses, zero power for distance and only reading addition for near. So that combination helped us to control the peripheral radiation stress also in certain conditions, those who are interested to use contact lenses. Using relaxation therapy also helped to reduce accommodation and control progressive myopia. Use of low concentration atropine also helped to reduce the stress on accommodation and control progressive myopia. Now, the last slide, like we recommend, the study is done on a small group of 200 eyes, or I can say 100 patients. So I suggest if you want to go into a deep of it, like we can establish it and we can assure all those patients who are coming with progressive myopia, we can give them this prescription. And if for that we need to study it on a larger group, and these are done in a metro city areas like NCR. So I can suggest this can be done at different location, wide variety of patients, and this time we have picked up inclusion criteria of only healthy patients, we can broaden this criteria in different subjective kind of condition disease patients also, and free environment also. Broader conclusion can be drawn and universally accepted theory can be created, and this would lead to a great success in control of progression of myopia. Thank you. I think this is all I can share, and thanks everybody for peaceful listening, and over to any questions if there is any.
Thank you so much, sir, for your wonderful talk.
Thanks, Sumit.
I request to Optum Anand Murthy, sir. I am delighted to welcome Optum Anand Murthy. He is a practicing optometrist in Delhi. He is an AIMS alumni and a postgraduate in clinical optometry. His practice is primarily focused at special emergencies and optical dispensing. He has also served as an assistant professor in Glaucoma University. Over to you, sir.
Hello, good morning.
Good morning. Welcome, Anand sir. Great to have you with us.
Good morning, Vikas sir. Good morning, Rohit sir.
Good morning.
And good morning, everybody. Thank you.
Sumit, Dr. Jadhavan is logged out. तो अब क्या हो रहा है, क्या सीन है कि जो ईमेल आईडी यहाँ पे डाल देनी है. Mr. Anand Murthy, please unmute yourself.
Hello.
Yes, sir. Please speak.
Am I audible? Yes. Am I audible? Hello.
Yes, Dr. Murthy, we can see your slide. Please start.
Okay. Thank you. Good morning, everybody, and corneal surface, so that effective error can. When we say orthokeratology, we basically mean myopic correction. Sorry for the interruption. Actually, there is network issue. So when we say orthokeratology, we basically mean a method by which we shape the anterior surface of the cornea so that the light rays are focused on the ray, like with any other method, like spectacle is generally referred to rigid lenses, reverse geometry rigid contact lenses that reshape the central cornea. But there are other lenses also, like which doesn't reshape the corneal surface, but apart from giving 6x6 vision or best corrected vision, it has the capability of controlling myopia due to the multifocal concentric rings. But in general, orthokeratology means that we are talking about the corneal small rigid lenses. Can you hear me?
You are audible. 100%.
Hello.
Yes, sir. You are
Audible
audible.
now? Okay.
100%. Yes, sir.
Okay. Slides are not visible. Can you see the slides, sir?
I think slides are not visible.
Anand sir, please share your screen.
I'm trying to share, but it's not visible. Let me rejoin. Just a minute.
Okay, sir.
Yes. So there are two terms that we generally use, that is myopia correction and myopia control. There is basic difference between correction and control. Whenever we use methods also to correct myopia, that is LASIK and some IOL also. But if you compare these two terms, correct by which we reduce the progression of myopia. That is called control. And correction means we correct the refractive errors so that we are able to see clearly immediate result or some result which they can But the peripheral images are formed before retina, means it still shows that the patient is myopic, and so the chances of elongation of eyeball is reduced. So orthokeratology converts hyperopic defocus to myopic defocus, and thereby decreasing the chances of progression of myopia. Even if you are not using any method to correct myopia, at least you can encourage your children to play outside, so that the progression of myopia can be reduced. Because we know from our experience that children, those who are playing outside, are more likely to have lesser myopia than people or the children those are into indoor activities more. I'm extremely sorry, slides are not visible.
No, don't worry, Murthy sir. We can see your slides. Lens parameter, spherical power, cylindrical power. Please go
Okay,
ahead.
you can see that.
We can see. You can speak out. No problem.
I think Anand Murthy sir is having a lot of technical glitches. So we'll be skipping on to the question answer round. If any of the delegate has any queries, please send in the text box. So I think we do not have any queries for now. We are skipping on to a short break and we'll be right back. So we are grateful to all of you. We are grateful to all of you who have accepted our invitation to be a part of this elite event. It's our holy tradition to worship our goddess Saraswati before any important event. So let's dedicate a prayer to Ma Saraswati. For that, I would like to invite our first year students of Bachelor of Optometry of AIMS New Delhi to present. Our virtual team, please play the Vandana video.
माँ हे शारदे माँ अज्ञानता से हमें तार दे माँ तू स्वर की देवी है संगीत तुझसे हर शब्द तेरा है हर गीत तुझसे हम हैं अकेले हम हैं अधूरे तेरी शरण में हमें प्यार दे माँ हे शारदे माँ हे शारदे माँ अज्ञानता से हमें तार दे माँ मुनियों ने समझी है गुनियों ने जानी वेदों की भाषा पुराणों की वाणी हम भी तो समझे हम भी तो जाने विद्या का हमको अधिकार दे माँ हे शारदे माँ हे शारदे माँ अज्ञानता से हमें तार दे माँ तू श्वेत वर्णी कमल पे विराजे हाथों में वीणा मुकुट सर पे साजे अज्ञानता के मिटा दे अंधेरे उजालों का हमको संसार दे माँ हे शारदे माँ हे शारदे माँ अज्ञानता से हमें तार दे माँ शारदे माँ हे शारदे
Thank you so much, girls. Now, may Goddess Saraswati bless us all. Thank you so much. Next, I would feel privileged to have Professor Sanjeev Lalwani, who has spent valuable years with us in AIMS. He is working in Forensic Department of AIMS New Delhi and is currently serving as the Registrar of AIMS. Over to you, sir. Now, may Goddess Saraswati bless us all.
All the dignitaries, members of the organizing committee, faculty members, and dear delegates, I warmly welcome you all at All India Institute of Medical Sciences, New Delhi, in AIMS Optometry Explorer 2021, organized by Optometry Students Association. I am happy to learn that this year, this is the sixth event in succession, and appreciate the efforts of optometry students for making it possible even during COVID pandemic. Ophthalmic techniques have evolved significantly over the years and have made significant contribution in community health and also achieving goals of various national programs. Every year, more than 800 delegates participate in this event, and again I can see the participation in this year as well in large numbers and with full enthusiasm. This year, we are organizing this program at AIMS New Delhi in hybrid mode because of ongoing COVID pandemic. I am happy to learn that event is involving hands-on training workshops and also deliberating on various important topics like teleophthalmology and new technology with high-end equipments for quality and high standard of patient care in this event. My best wishes to all of you for great learning experience in this event, and I hope that you will be returning back rich in knowledge. My best wishes again to the members of our organizing committee and to all of you. Thank you very much. Jai Hind.
Thank you so much, sir, for your kind words. Now, I would request to invite Professor Rohit Saxena, currently the chairperson of Bachelor of Optometry in AIMS New Delhi. He is serving as a professor in Dr. RP Center of Ophthalmic Sciences. He has been taking care of us with full enthusiasm and dedication and is always standing as support pillars with us through our thick and thins. Thank you, sir. Over to you, sir. Currently the chairperson of Bachelor of
Good morning,
Optometry
friends.
in New Delhi.
It is an absolute pleasure and an honor for me to welcome you all to this Optometry Students Association Annual Conference. This is the sixth such wonderful, outstanding conference, and which is being held from on 20th and 21st of February, and with the theme of embodying technology and culturing excellence in primary eye care. We all know that the past year has been very difficult for all of us, for research, for teaching, and for meeting friends, and for being able to do the service for which we are all here and trained. But it is wonderful to see that now things are getting back. This conference and meeting is sure to help you to tackle the problems that you are facing while managing patients in the COVID era, and hopefully it will help you to learn how to transit from these conditions to actually go back to treating patients physically. And we look forward to the day when we start resuming our life. But in the meantime, I welcome you all here. I'm sure over the next 2 days, you're going to enjoy yourself, learn, make friends, and be a better manager, a better consultant, a better treating physician to the patients who come seek your help. So all the best, and I congratulate the team of OSA who have worked hard to bring for you this excellent conference, which I'm sure you will always remember for many years to come. All the best to the team, welcome to the delegates, and thank you everybody for being here.
Next, I request the President of Optometry Students Association, Mr. Vilmal Saroha, to please address the audience.
Hello everyone, myself Vimal Saroha, and I'm the president of Optometric Students Association, AIMS New Delhi. On behalf of OSA, I extend a heartily welcome to all of you present here. AIMS Optometry Explorer has been a signature event for the B-Optom student of AIMS since many years. I personally believe that this is an opportunity for the students to explore the best out of it. This 2-day session will be eye-opening for all the attendees out here. Optometry is changing, and the change of pace is now getting really fast. We no longer are going to be only able to provide healthcare to the general public in this very traditional primary care setting and secondary care setting in few years. So the role of optometry is centrally going to expand. So one of the key things on the back of that is we really do need to expand what we do, and what I would really like all the attendees to do is to really start investing their future careers with learning new skills and expand our future knowledge to make sure we enhance our clinical skills and knowledge to provide these services that surely we will need to provide in future. I wish you all a happy knowledge sharing time. Thank you everyone.
Next, I would request the General Secretary of Optometry Students Association, Mr. Kamlesh Mali, to address the audience.
Good morning to all. Myself, I am Kamlesh Mali, Optometry Student Association General Secretary. I am really privileged to have the pleasant task of welcoming the distinguished gathering for the AIMS Optometry Explorer 2021. On behalf of the Optometry Students Association, I am highly honored that our Honorable Registrar and our Chairperson is amongst us today. We are indeed grateful to them for graciously and radially accepting our invitation. Let me extend my thanks to all. Presence is always a moral booster for us. I thank you all for attending. I look forward to wonderful events to follow. Thank you, everyone.
So we'll be right back after a short break. Till then, stay tuned with us. Thank you. So we'll be right back after. है ना?
हाँ हाँ हो गए हैं भैया, हो गए। तू कर अपना स्टार्ट।
Good morning, everyone. In the continuance with the conference, we are going to proceed with a new session unveiling the topic innovative optometry. In this session, we will proceed with firstly ocular prosthesis, secondly behavioral optometry overview, and for the last professional laws and AHP bill, followed by panel discussion. So we will move towards the first talk presented by Optom Sachin Gupta sir. He is board certified ocularist from USA, practicing in New Delhi, India since 2006. He has experience of serving more than 5,800 patients for ocular prosthesis and 150 patients for orbital prosthesis. He is involved in research in developing new techniques in the field of ocular history and anaplastology. At present, he is Secretary of Ocularist Society of India and teaching faculty in various universities in India. Sir, please enlighten us about ocular prosthesis with your thoughts. Over to you, sir.
Just hold on, I'm just trying to connect. Give me a moment. Can you see my screen? Hello? 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 Can you hear me? Can you hear me? Hello? Can you hear me? Hello?
Yes, sir. Yes, sir.
Can you hear me?
Yes, sir.
And just, can you see my screen?
Not yet, sir.
Can you see the screen?
No, sir. Sir, you are audible.
I've already shared.
Sir, we can't see your slides. Share your screen, sir. Yes, yes. Yes, sir.
Okay.
Yes, sir.
Can you hear me?
Yes, sir.
Okay, all right.
Okay.
So hello everyone, good morning to all. Hope everybody is following the government's guideline and all are safe and healthy. I am Sachin Gupta. I will be presenting on ocular prosthetics, what every optometrist should know. So stay tuned. I would like to mention here that I do not have any financial interest on this presentation, and I request you all not to take pictures or a screenshot. So during my 12 minutes presentation, I will try to cover the following headings: introduction of ocular prosthesis, who needs them, what is custom ocular prosthesis, difference between ready-made and custom-made prosthesis, and myths and facts about it. So begin with the introduction. What is ocular prosthetics? First, we have to understand this term, ocular and prosthetics. Both words are originated from late Latin language. Ocular means eye, prosthetic means artificial. And by the definition, ocular prosthesis is a prosthetic device which is used to hide the disfigurement of the eye. Hope you guys know this man, an American actor who is the face of Mission Impossible series, Tom Cruise. One of the highest paid actor in the world. He was also selected as one of the most handsome men on the earth because he got the great looks. Just think, if unfortunately he has some deformity on his face like this, or like this, or this. Facial beauty is very important in this aesthetic oriented work. So such patients with disfigured eye need cosmetic corrections in form of ocular prosthetics, which can hide such defects, and ideal prosthesis should match in size of the eye, shape of the eye, lid's contour, centration, color of the iris, size of the iris, size of pupil, and color of sclera. So when we are making a prosthesis, these are the points which we match. We have to take care of each points when we are making a prosthetic eye. So due to the need of such cosmetic enhancement, the world is working from ages to improvise its manufacturing technique. In ancient time, artificial eyes were made up of metal, glass, porcelain, glass, etc. In fact, before Second World War, Germany was manufacturing the glass eyes and supplying to the whole world. But after Second World War, America developed the acrylic artificial eyes made by PMMA material, which has several advantages over the glass eye. And nowadays, most of the world make artificial eyes by PMMA. Even we make prosthetic eye by PMMA. So coming to the second heading, who needs them? Well, there are various unfortunate conditions like injury, infection, post-field graft surgeries, glaucoma, corneal disorders, microphthalmos, tumor, chickenpox, dengue, etc., where these conditions cause disfigured eye. To elaborate more in scientific terms, the first condition called as phthisis bulbi, which is commonly known as shrunken eye or white eyes. The main cause of phthisis bulbi are injury, infection, post-failed surgeries, multiple surgeries, glaucoma, and corneal disorders. This is the commonest condition which we see in our OPD or at optical outlets. These patients usually do not require any surgery and directly can go for the prosthetic eye. This is Ocular's first choice to fit the prosthesis because Oculars can expect a good result in such cases. And the movement is also very good over the phthisis bulbi. Next is anophthalmos. It means N means no, ophthalmos eye. So anophthalmos means there's no eye. The main cause of these conditions are severe injury or infection, tumor, or painful blind eye. Basically, there are two surgical procedures, enucleation or evisceration. I'm not going into the details, but with these surgeries, the surgeon remove the eyeball and they put an implant. And after 4 to 6 weeks, patient go for the prosthetic eye. Next is congenital disorder, which is microphthalmos or congenital anophthalmos, in which child is born with small or no eye. So what we do in this, we put a prosthetic eye or we put custom conformer. We put a tiny conformer inside the socket. If you see here, sorry. So if you will see the second picture, here the bluish thing is a small conformer. When we put it into the socket, we give little pressure, and with the help of conformer and pressure, the socket grows. If you will see the third picture, here it's showing the fornix are growing vertically. So it helps in socket expansion. In these two pictures, you see the first picture, the picture on the left on the screen shows a small socket, which is for the microphthalmos, and with the after the treatment, the socket expands and eye grows with the conformer. The next is post-exentration, where the surgeon has to remove the orbital contents like eyeball, eyelids, skin, and other orbital parts. And the treatment is orbital prosthesis which can be attached either with the adhesive or it can be spectacle mounted. It is a very advanced type of prosthesis. These are some results of post-exentration. So we spoke on who needs them. Now I would like to demonstrate what is custom ocular prosthetics. So basically there are two types of prosthetic eyes. One is stock eye and second is custom eye. Stock eyes are made in factories or in laboratories in absence of patient. They are mass produced and they are mass produced by fixed dies and with a fixed size and shape. This can be fitted with trial and error, and whatever suits the best can be dispensed to the patient. And this is a temporary treatment. Custom-made artificial eyes are handmade in ocularist lab in presence of patient. So when an ocularist is making a prosthetic eye, as I shown in the previous slide, they take care of all the 7-8 points in size, shape, color, and other things, and it is made according to the fellow eye. It is exclusively made for the individual, gives best possible movement to the in the prosthetic eye, and there is no need of frequent cleaning in this prosthetic eye. So basically, this is more comfortable. So this is the slide which I would like to explain here. This is showing the fitting of ready-made and custom eye. The first picture on the left side picture on the screen shows the fitting of prosthetic eye. You see the point B, which is shown in yellow color, shows the gap between the ready-made eye and the socket. What happens in this gap? The tears collects, accumulates, and becomes discharge. So discharge is a major problem in stock artificial eyes. I'm talking about the comfort level. So because of the discharge, patient has to clean this prosthesis very frequently. They have to remove this prosthesis before they sleep. On the other hand, if you see the picture, right side picture on your screen, there's almost negligible gap. So there's no gap, practically no gap between the prosthetic eye and the socket. So there's no discharge collection, and patient can use the custom prosthetic eye for very long period, like for 1 month without removal. It doesn't require frequent cleaning. And because of that, the movement is also good because the custom eye has a better grip over the socket. So better grip means better movement in the prosthetic eye. So instructions when somebody is using a custom ocular prosthesis, they can clean it with baby shampoo and water. There is no chemical required to clean the prosthetic eye. And often they can, if they want, they can clean it with a RGP contact lens solution, but there's no, we don't recommend to clean it with sanitizer or toothpaste or any other cleaning agent. They just need a very gentle cleaning. Baby shampoo is more than enough. They can remove it once in a month because, as I showed, there's no discharge collection in the prosthetic eye, so they can keep it in the eye. Custom prosthetic eyes needs polishing once in a year. If we polish the prosthesis, it becomes very smooth and deposit free. And patient can change the prosthesis after 5-7 years. What happens when somebody is using prosthetic eye? There are some changes in the socket, in the fornix or in the muscles. So they should change it after 5 to 7 years. There are myths and facts about the prosthetic eyes. I would like to highlight them. Somebody says that it's made by stone material, which is not true. It's made by acrylic material, PMMA material, which is an inert material, very biocompatible material. And second myth is age is a factor. There are many times it's said that the prosthetic eye should be fitted after the age of 14 or 16 years, which is not true. There's no age bar. In fact, in pediatric cases, it should be fitted as early as possible for better socket growth. It's said that prosthetic eye needs frequent cleaning. No, it's not required. In custom eye, it's not required. They can clean it once in a month, which is more than enough. The next myth is removal before sleep. It is said that the patient cannot sleep with the prosthetic eye in. No, this is not true. Prosthetic eye can be used while sleep. Some doctor says, or some professional says that it looks odd. If it is well made, it is a well fitted prosthetic eye, it is almost unrecognizable. In cases of pediatric cases, it is a myth that somebody says that it needs frequent change. Like kids are growing very fast, so they need to change after 3 months, 6 months. No, which is not true. Custom eye can be modified. A kid patient can use it for 3 to 5 years, the same prosthetic eye, and it can be enlarged according to the socket. This everybody knows that prosthetic eye cannot restore sight. And many times patient ask whether it is covered in insurance. Unfortunately, in India, it's not covered in Insurance Act, though people are working, and we expect that very soon it will be covered in the insurance. One more myth which is not mentioned here, the many times patient ask whether the person
Hello,
who is a
sir. Hello, sir.
yeah.
Sir, sorry to interrupt. Sir, Professor Ramanjit Chhota is joining.
Okay.
So we will start after. We will begin again after a short break.
Okay, but it's my last slide.
Okay, sir. Continue.
Okay, so sometimes patient asks the one-eyed patient can get driving license or not, but in India, a one-eyed person can get driving license, and this is the clause in a Motor Vehicle Act in 1984. So coming to the conclusion, custom ocular prostheses provide excellent comfort, cosmetic appearance, self-confidence to the patient, and prevent socket complications. Poor fitting stock eyes give temporary solution, but in future causes a lot of irreversible socket complications like this. So hope you won't leave such patients untreated. You can refer them to your nearest ocularist. So get the best look. Thank you.
Sir.
So this
Thank
was
you,
the
sir.
transition.
Thank you so much, sir. Good morning, ma'am.
Good morning.
Professor Ramanjit Chhota, currently heading the Glaucoma Research Facility and Clinical Services at Dr. RP Center, AIIMS, New Delhi. She has more than 35 years of experience and has won numerous national and international awards for research in glaucoma. She is the past president of the Glaucoma Society of India. She has written 16 chapters in books and published over 130 papers in peer-reviewed, indexed, and international journals. Over to you, ma'am.
Can you see the video? I mean, can you see the slides? Huh? Are the slides visible? Are the slides?
No, ma'am. No, ma'am.
Oh, okay. Share screen कहाँ है? ये? Sorry. Now?
Yes, ma'am.
Okay, all right. So I'm sorry about the problem with time. I think between us and your technical problems, we've lost a little bit of time, but I'd just like to say how important optometrists and ophthalmic technicians are to glaucoma, because we have many patients. The prevalence of glaucoma in India is that if you look at 20 people, say in Sarojini Nagar, at least one of them is likely to have either glaucoma or be a glaucoma suspect. We can also get glaucoma at every age. They can be children who come to us, one day of after birth. You can have ladies or middle-aged people coming, and then you get the elderly as well. So all of them need to be looked after. And one has to remember that it's a chronic optic neuropathy, with the main risk factor being a raised intraocular pressure. And this is some place where we think that, a routine test, a comprehensive examination for every patient who comes into a clinic or a hospital would identify people who are likely to be glaucomatous. The other risk factors are vascular, because if there's poor ocular perfusion, then the optic nerve is unlikely to function very well. So in India, what we find is that we see about 1/3 of open angle glaucomas, 1/3 angle closure glaucomas, and 1/3 secondary glaucomas. So I think this is the other thing to keep in mind, that as compared to the rest of the world, we are likely to see a lot of traumatic glaucomas, steroid-induced glaucomas, all of which actually come to us for something else. And then over a period of time, the glaucoma develops and they lose vision. And the vision that is lost in glaucoma is irreversible. So for all these reasons, if we know that this is what we are likely to get, then we look at the eye carefully. We look for shallow anterior chambers. We look for other diseases like uveitis, trauma, and things. And the earlier you pick it up, obviously, it's going to be the easier to treat and the easier to stabilize. All right. So if we keep this in mind, the fact that we are seeing so many people who are blind is actually a shame. It's also a huge cost to society and government, and it is something that we can actually prevent. So as I said, 1 in 20 people over the age of 40 are likely to either have glaucoma or be a suspect. As compared to the rest of the world, which only sees open angle glaucomas, we have a huge component of angle closures. So you can either be a suspect, angle closure suspect, or have some evidence of closure, or you develop the optic neuropathy and become primary angle closure glaucoma. So in the screening for glaucoma, just looking at the anterior chamber, this is only a torch that has been shown from one side, from the temporal side, and you can see the nasal area is not actually illuminated because the iris is actually steep in this fashion and therefore blocking the light from coming through. So anybody can look at the anterior chamber and say, okay, this is shallow, I need to do something else for it. If you have a slit lamp, doing a Van Herring test is very easy. Again, you look at the most peripheral AC depth as compared to the thickness of the cornea. And if it's less than a quarter, then you know that you're in for trouble. And this patient probably needs a gonioscopy and a YAG iridotomy. Also, if you look at the iris itself, normally we know the iris has a beautiful pattern. But when you see an iris with no pattern or without a pupillary ruff, then you start thinking to yourself, there is a problem. I mean, it's one amongst many that you could have angle closure glaucoma, but it could be uveitis, it could be diabetes, it could be many other things. So just looking at the anterior chamber is enough to give us some sort of idea about an abnormality. Then, of course, we look at the fundus. All right. In a normal fundus, this area would probably be only 0.3 is to the total diameter, vertical diameter of the disc. And here you can see, if you look at where the blood vessels are turning, you can see they're almost at the edge of the disc, and here they are at the edge of the disc. So this would probably be almost a 0.8:1 cup disc ratio. So you look at the anterior chamber, you look at the fundus, and then you must do an intraocular pressure measurement. And there are many ways in which this can be done. So with tonometry, the gold standard remains the applanation tonometer. And this is what we are looking for the endpoint to be, that the inner part of the two hemispheres actually touch each other. And there's a little bit of pulsation at that point so that you know that the cardiac pulsations are showing through. And this is just a slight oscillation up and down here. There are other ways of doing it. There are many newer ways of doing it. There's the tonopen, there's the ORA, there's Corvus. But I think this is still our gold standard because this is actually reproducible. While these, though they have smaller tips and can be used in certain circumstances, actually show a great variability. And they do not actually coincide with the Goldman tonometer beyond a certain limit. So between, say, 10 and 20 millimeters, all of them are pretty accurate. But if it is very above 20 or below 10, these are going to show you much more variability than the Goldman. So again, with the applanation tonometer, please remember that we just want to applanate. We don't want to push it in. Because if you push it in, what you're going to find is that there are many kind of fallacies that would come into it. All right. So if you have a very wide mya, obviously what you're going to have to do is to push further inside, and therefore you're going to record a much higher IOP than there actually is. If it's a very thin mya, you're going to see it as soon as the prism touches the cornea. So there are many sort of fallacies. I'm sure you're aware of them, but be cognizant of the fact that your corneal curvature, edema, even doing an applanation 2 or 3 times can affect the reading that you do. So we do say take 2 readings just to make sure that the value that is coming is the same. Otherwise, if the patient is squeezing initially, you bring something close to the eye, the patient squeezes, and the intraocular pressure the first time you recorded maybe 26. Within a couple of minutes, you reassure the patient. You say, now you've seen how it is done. You know it's not going to cause you pain. Keep your eyes open. Keep the other eye open. And when you repeat the IOP, it's likely that it will come down to 16 or so. Okay. So you must repeat the IOP, but you can't repeat it 3 or 4 times at the same in continuation, because then you'll find that the reading that you get would be falsely low. With the squeezing, you can get a raise in IOP up to almost 30, 34, 36 millimeters of mercury. All right. And whatever you use, remember it has to be calibrated and it should be checked at least twice a year. All right. And when we look for intraocular pressure in glaucoma, I think we have to remember that the intraocular pressure during the day between 10 a.m. and 7 p.m. is pretty much on the lower side. If you are looking for high pressures, you're more likely to get them early in the morning or late at night, which is why in RP Center, you've seen that we do a diurnal starting at 7 in the morning and ending at 10 at night. Now the fundus, I showed you another one earlier, and you can see here as well that this blood vessel has come up the cup and going onto the surface. So you can see this is the edge of the cup. But when you look here, you can actually see the blood vessel is coming out onto the surface only at the edge. In addition to which, you can see this retinal nerve fiber layer defect, wedge-shaped retinal nerve fiber layer defect. So I'm sure all of you are good at looking at the fundus. And it is important that you look at this fundus not only in one eye, but you compare the two, because both eyes, by and large, if you look at our hands and legs, we're fairly symmetrical. But if you find a difference in the cup disc ratio, this would probably be again 0.8 or so in this eye, and you find the other one to be 0.4, the chances are it is glaucomatous. On the other hand, there is a chance that you might find that there's a congenital anomaly. Maybe there's a coloboma over here, and this is exactly the same on the other eye. So then you have to think to yourself, is it a developmental anomaly or is it glaucoma? And then see what happens further. Now, when you find a patient who is probably a suspect, you want to see what is happening to the patient over time, because if you remember, the definition was it's a progressive optic neuropathy. So when we are in doubt about the diagnosis, then we have to look to see what is happening over time. And always remember that structural change precedes the functional change. So visual fields are likely to be affected when many of the axons are lost. Between 40 to 50% have to be lost before we actually can get a visual field effect. So when we do digital imaging, which these days I think is largely by OCT, but we have many years of experience with the HRT, you can actually put one, say, an image taken in 2000 on the image at 2002 and the image at 2004 and see if there's any significant difference. And this is with the confocal scanning laser. You can do what is called a RNFL, that is, you're measuring the retinal nerve fiber layer thickness, or you can look at the macula, or you can look at the ganglion cell and its loss in and around the macula. So this is, as I said, the types of glaucoma that we're likely to get. And on gonioscopy, if you do a gonioscopy, this is an open angle. This is an angle in which the iris is steep and therefore has blocked the trabecular meshwork in angle closure. This is something I've already spoken to you about. These are the gonioscopes we use. And these are the pictures you're likely to see, a wide open angle becoming gradually narrower in this diagram. But in a patient, you're either likely to see this or this or this, 360 degrees using either a 4-mirror or a single or a 2-mirror gonioscope. This is the gonioscopy in an open angle. You can see that there are a few iris processes over here. No pigmentation whatsoever. Here again, if you look at the angle is probably about 40 degrees or more. And you can see this is a wide open angle with the gray ciliary body band seen here and the white Schwalbe's line seen over here. As compared to that, you can see the convexity of the iris. Here you can see the iris is flat. This is the convexity of the iris, and you're seeing nothing of the angle. You're just seeing the cornea, and then you begin to see the iris, telling you that this is an occludable angle. And if you push a little bit, manipulate a little bit, or indent a little bit, it may open up to give you these kind of synechiae. This is the cornea. That area here is the trabecular meshwork, which has been completely blocked in areas. These are synechiae that you can see. In angle closure, there are many reasons why this angle closure occurs. And the best way to check this out is either with an anterior segment OCT, in which case you can see the plateau iris like this. You can see a relative pupillary block. You can see a very thick lens, or you can do a UBM. All right. So in primary angle closure, the first thing we tend to do is to do an iridotomy. And you can see this patient over here. This is the area of the trabecular meshwork. It's completely blocked by the iris. Once we do the iridotomy, you can see that this has opened up. The same area has now opened up, and you can actually have some function. This graph, this is from a Cassia anterior segment OCT, showing us how high the iris was actually touching the trabecular meshwork. This is the area of the trabecular meshwork. The iris was way above it. After the iridotomy, you can see it has reduced. So this is the efficacy of the iridotomy, which we must look at. And how does the optic nerve sort of correlate with what we see on the visual field? Because it is important. You can't look at the optic nerve in a patient and the visual field, which doesn't corroborate. So here you can see there's a loss in the inferior temporal area showing up as a visual field defect in the superior temporal. You can grade the visual field defects into mild, moderate, and severe. And you can use imaging techniques. And as I said, largely now we seem to be left with only the OCT. And if this is a good signal strength, which is why I think the optometrists and the technicians are so important. If you don't get a good signal strength, then this is a useless test and you'll be charging your patients 4,000, 5,000 rupees. So be sure that you do a good test, a good signal strength, and then it gives you many sort of objective parameters, which over time can help you to actually see what is happening to the patient. So this is a patient you can see has been followed up for many years. And it actually shows us differences. This is an HRT, which occurred 4 years before the visual field defect actually showed up. And similarly over here, you can see perimetric progression and you can see the progression on the imaging as well. So to end, I would like to say that, you don't need very much to help in the treatment of glaucoma. You need a slit lamp, you need an applanation tonometer, a gonioscope, and the ability to actually ask what medications the patient is on, both topically as well as systemically. You should either be able to get or refer a patient for a perimetry and they register into a kind of glaucoma clinic so that the patients are reviewed regularly. There's a phone app which we can actually use for auditing our patients. So as I said, these are the things we actually want you to do and do well. But at some point, there is going to be some visual disability in a patient with glaucoma. So you should be also prepared to help with the LVA. And for some reason, these absorptive lenses are actually improving the patient's visual quality of life because they actually reduce the glare and they also increase the contrast. Other things that can be used are telescopes. You can enhance visual fields with high minus lenses and in the form of a reverse telescope. You can actually help the patient enhance whatever remaining vision he has. So if we actually look at ways in which both the patient and the optometrist can help in glaucoma care, the first is to keep reminding the patient what time should you put the medication. So if it's a BD medication twice a day, it's not good enough to put it at 8 in the morning and 12 noon. You have to tell them it's a 12-hour interval. So 8 in the morning and 8 in the evening. The second thing to keep emphasizing to patients who come to you is that they need a lifelong review. They cannot go one day and then maybe wake up 6 years later and say, I'll go back again. You have to make sure that they can afford the medicines, that they are actually putting the medicines in, and constantly keep asking for steroids, because in India, over-the-counter steroid are freely available and frequently used for things like asthma, dermatitis, and in homeopathy. For the optometrist, I think it's important to know that, which systemic problems are likely to actually interfere with the medications being given for glaucoma and which can actually increase glaucoma. So as I said, for asthma, people are given inhalers and they are constantly told inhalers don't produce a problem, inhalers don't cause glaucoma, but we know they do. So if you do find a patient using steroids in any form, patients who have all these problems, you should bring it to the attention of the consultant. For tonometry, remember, we need to get very accurate readings and at least 2 readings should be taken at a time. And if you're doing an NCT, please take at least 3 readings and they should be similar. A diurnal must be done or at least tried early morning and late at night. We need very, very good quality imaging perimetry. There's no point in doing a perimetry for the sake of it. If you don't have rimless lenses, your perimetry is going to be useless. If you're not talking to your patient through the perimetry, it's going to be useless. If you don't actually check to see the scan quality of your OCT, it is of no use to anybody, to the patient, to the doctor, to you, not at all. And remember that there are many low vision aids which are available, which are simple, that can improve the visual quality in patients with glaucoma. Finally, if somebody does come to you and say, I need a pair of glasses, and you ask and he says, oh, I'm on glaucoma medication, please remember to say that if you screen your relatives, these are familial diseases, you can pick up the glaucoma early and make sure that patients don't progress. I think optometry is a very important part. This is the ministry chart on glaucoma management, and I think the optometrists should all be aware of it. And actually, we need you to help us to decrease the number of blind that we have because of glaucoma. So today we have very good medications. Our surgeries are much safer. We can do to achieve our target IOP. We can prevent or slow progression, but we need a lot of help, and we need a lot of your help. Thank you.
Thank you, ma'am, for your kind words. Thank you, ma'am.
Any questions or?
Thank you, ma'am, for your kind words. Thank you so much.
Thank you. Thanks. Shall I leave this on?
In continuation of our previous session, Innovative Optometry, now let us move towards our next topic, which is presented by Ms. Mayuri Deka. Ms. Mayuri Deka is currently Assistant Professor and Academic in Charge at Ridley College of Optometry, Jorhat, Assam. She has completed her B Optum from WBUT, Kolkata, and then pursued her M Optum from Bharati Vidyapeeth Deemed University Medical College, Pune. She is in the profession of teaching since 8 years, guiding and mentoring students as well as interns. She has also written many optometry articles published in the Indian Optician. I am honored to invite you to speak at the topic Behavioral Optometry Overview. Ma'am, please enlighten us with your kind words. Thank you.
Hello, everyone. I'm glad I'm a part of this webinar, and I hope everybody is fine. Am I visible to you and audible as well?
Yes, ma'am.
Okay. Give me some time for sharing.
Sorry, ma'am.
Yeah, give me some time for sharing my slide.
Okay, ma'am.
Let's see why I'm unable to.
Ma'am, we will back to you soon.
Next panelist के लिए.
Next. Okay. Now we will move towards the next session, presented by Optom Rajesh Vadwa sir. He is an optometrist qualified from AIMS in 1983. He is Masters in Optometry and PG Diploma in Management. He is a part-time educator and routinely lectures at university in India and in Asia Pacific region. He was awarded Lifetime Achievement Award and Fellowship by International Association of Contact Lens Educator from Australia. Ma'am, sir, please start your session first.
Good morning, everybody. Mayuri, can I share my screen? Is your screen being shared? Yes.
Sure,
Thank
sir.
you.
Please go ahead.
Thank you
Yes,
so
sir.
much. So, here we go. Can you see my slides, please? Hello, can you see my slides?
Yes, sir. Yes, sir.
Okay. So good morning. Today we are going to be talking on professional law and AHP bill. This is something which is very significant as the system is changing, Indian scenario is changing. I am an optometrist primarily, but I also happen to possess qualifications in law with specialization in medical law and bioethics. So I thought it will be good that we all get aware of what is in. Now, this image, what does it really symbolize? It symbolizes the hard work that our predecessors have done. They've done selfless work, spent all their effort, time, resources in order to move the government. And now we are going to see the light, and we are going to see optometry as a recognized profession in India very soon. This really calls for an applause for all our predecessors who worked so hard for so many years. So many means more than 60 years. They've been working hard on this. The National Commission for Allied Health, Allied and Healthcare Professionals Bill 2020. This is what the bill is called, and it has already been presented in the Parliament. Now, why this bill is the first point. It will be called an act once passed by the Parliament. It's going to be, after discussions or any modification, that will become an act. Question is, why this bill? Why did we need this bill? What will it do? It's going to be a game-changing process. It's going to be a change in the total future of optometry in India. The optometrists after this bill will be registered. They will be regulated by certain principles and systems. We will be healthcare professionals. The optometrists will be classified under healthcare professionals and will have more rights. There are no rights without responsibility, that we all know. So responsibility and answerability both will increase. So answerability on what? Rules will guide, qualification. Only specific qualifications will be permitted. Soon we will see which qualifications will be called optometrists. Then the behavior, etiquette, how you deal with the patient will also be regulated by the rules. What will be your performance like? And there will be strict accountability of all the clinical work done. Do we feel happy or scared about it? That's the question. Answer is there is no scare. Scare is only when we do not know what is happening. Law is a friend, and do not look at law as a scary tool of harassment. This child is afraid because he's seeing an unknown face. But what if he knew this person? The child would smile. So would we. So let us know the law and not be scared of the law. Now, purpose of the bill, they can be all this long definition, but let us look at the keywords: regulation, maintenance of standards, not only of education, but of services also, of allied and healthcare professionals. There are two groups. One is allied group and other is healthcare professionals. Now, putting it to the side, why should we know these laws, first of all? Well, in India, it is established that we must know the law because ignorance of law is no excuse to escape the consequences. Someone is asked to produce all the case sheet of a patient. He says, I never made it, but the law says you should make it. So he'll say, I did not know it was a law. That will not be an escape. That will be counted as a problem. So we discuss here, what does AHP bill say and the professional law other than AHP which will be governing us. The AHP Act is yet to come. As we said, it is a proposed law and we are listing the interpretations of this bill. Once it becomes an act, we will know specifically what it is. And all the contents of this bill are not known and are not predicted because in discussions in Parliament, things may change. There might be some changes in final act, so expected time of enactment is next session of Parliament because this running session is almost over. So consider the upcoming information as almost accurate information because it may be tweaked after discussions with various Parliament members. Allied has been defined, such a big definition of who are allied health professionals, but to us, what is important here is this is a group of people who will be there to support, and their education after schooling will not be less than 2000 hours. They are the support people. Why we are going so fast on this one screen? Because optometry is being classified as a healthcare profession, not as allied health. Therefore, this goes out and we look at healthcare professional defined. Such big definition, and the keywords are these people will be healthcare professionals, will be professionals who study, they advise, they do research, they supervise, they provide preventive, curative, rehabilitative, and therapeutic or promotional health services. So this is what will be, and the education will not be less than, will be a degree which will be not less than 3,600 hours. So that means 3,600 hours of education is minimal. These people will be classified and registered as optometrists. There is another definition of ophthalmic sciences professional, and this ophthalmic sciences professional has two parts under it. We will be coming under ophthalmic sciences professionals, and they are the ones who see the disorders of the eye, the visual system. We all belong to that. Two categories. Category one is optometrist. There is an international standard classification of occupations, which is called ISCO code. Under that, we are number 2267. And the second group is called ophthalmic assistants or vision technicians who do less than 3,600 hours, and they do 2 years of diplomas, and their classification code is 3256. When it starts with 22, then usually they are the supervisory and independent roles. And when it starts with 32, they are the assistants and supportive roles. But let us see how the final bill comes up. So duty of National Commission, there will be a National Commission and there will be State Council. So duty of National Commission will be, it shall be the duty of the Commission to take all such steps as it may think fit for ensuring coordinated and integrated development of education and maintenance of standards of delivery of service under this Act. So service and education both will be controlled by the National Commission. But who will do the work for National Commission? National Commission sitting in one head office cannot be controlling the whole country. So here comes the State Allied and Healthcare Council. Next 3 slides are going to be a little busy, so please bear with me because we are going to list out the role of the state councils. It will ensure that the functions of the commission are met. So what the National Commission was to do will actually be done by state commission or the state councils. So they will enforce the professional conduct, code of ethics, etiquette, everything about the professionals. They will ensure minimum standards of education, course, curricula, physical and instructional facilities, and they will see that all the clinics are well prepared and well created with minimum standards. They'll ensure uniform entry examination with common counseling. Just like if there is an admission for, say, IITs, a common exam happens and then people are just distributed in counseling. Similar pattern will be one day formed by these state councils. And they will ensure uniform exit or licensing exam. It's not that you just completed your 36 hours of training and there you go into the clinics. No, you'll have to be passing an exit exam before you get a license. That'll be a licensing exam or exit exam, so that even if certain institutions have not given good education, their candidates will have to relearn a few things before they can pass the exam, and then people's eyes are given into their responsibility. Further, the duty of council will be to inspect the institutions, the college, the university, to see that all basic requirements for training are there, for teaching the students are there. They'll ensure compliance of all the directives issued by the commission, and also do all those functions which the state government may ask them to do. They will create, the state government will, the state register will be there by the state council, and this will be a public document. You'll be able to see it on the internet. What will be about the central register then? The national register or the central register will be populated by all data which state councils will put in, and this will come in here. Whose name can be there on register? There are 3 things, 3 criteria to be met. Number 1, that someone applies for it. Number 2, payment of the prescribed fee, whatever is required for registering the name. And third, which is most important, the person who is applying and paying the fee should have a recognized allied and healthcare qualification as is defined there. Every person as above who offers his services on or before the commencement of this act will register within 2 years after the act comes in. Up to 2 years, they might be provisional, and then it will come to be a compulsory registration, and no one will be able to work without registration as an optometrist. Renewal will be every 5 years by the state council by paying a prescribed fee or whatever methodology or conditions are prescribed. Now, foreign qualification. If an Indian has a corresponding foreign qualification from abroad, that will be recognized subject to reciprocity. Reciprocity is that if a country, for example, say USA says, I have this degree which is equivalent to B Optom of India, so USA has to recognize our qualification, only then we recognize US qualification. This is done by the national government. Once reciprocity is there and corresponding qualification is there, an Indian national staying abroad or having studied abroad can also come in and have the register done. Now, let us not take this lightly. You may recollect your childhood hero, the He-Man who said, I have the power. Yes, this particular AHP bill grants immense powers to the commission. Let us see. Suppose someone just walks in and says, okay, I am an optometrist and here I am having a practice. He was not registered. So he puts in falsely as if he is registered. So first conviction with fine, which may extend up to 1 lakh rupees. But if he repeats, then what happens? Subsequent conviction with imprisonment, which may extend to 1 year, fine not exceeding 2 lakh rupees or both, is going to be stringent. So one has to be qualified to start optometry practice in future. Will the complaint go directly to the court? Someone says, this man was not an optometrist, or he did a misconduct or something as an optometrist. Will he go to the court? No. He will complain to the state council or the national commission. Now it's for the government, central or state, or the commission or the council who will go to the court, and a court which is not lower than a metropolitan magistrate or a judicial magistrate of first class who will be trying this. Suppose someone says, oh, I am all qualified and I have every criteria that my name should be there in the register, but the government is refusing. You cannot go to court for that. Number two, if government does something, suppose government does not register someone, and later on the government accepts after 2 years, yes, you can be registered. In that case, government cannot be sued because they did it in good faith for whatever reason. So this case will have this particular act will have an overriding effect. It will be overriding, and any other previous law will be in background. This is what will be actually considered as the law which will be implemented, even if they are in contravention of each other. I hear some background sounds, please. Somebody's mic is on. Mr. Sumit Jadon, please put off your mic. If removed from register by a commission, what will happen? The order will come in force after 3 months. So within 30 days, someone can apply and appeal against that removal. And within 90 days, the commission will have to give a response to that request. And when this request is given within 90 days, until then, his name will not be removed from the register. The name can be restored and it will be uploaded on the website and published in the official gazette, and that person's name will be again there. And it will also be published in the local newspapers in vernacular language. So what is the bridge between the bill and the act? When the bill was made and now the act will come, several suggestions by optometry were given to the Standing Committee of Parliament, thanks to the leaders who drafted and represented there. These were sympathetically noted and by government representatives, and we hope that the bill which will come will be acceptable to all, that is to professionals, to society, to government, international community, and to public at large. Having discussed this part of AHP bill, just a minute more to talk of other aspects of the law which governs us. So far in India, use of drugs is not permitted to optometrists. So we should have drugless and non-invasive practice. Usually law is same whether we talk of drug being systemically used or topically used. So go ahead and do non-contact tonometry or non-mydriatic fundus imaging, but do not perform applanation tonometry independently. As of now, once the rules come in, the act comes in, permissions will come in, and then we'll be able to do even these independently. Optometrists can be sued either in civil or in criminal. So civil will be Consumer Protection Act, and for negligence under criminal proceedings also. So care will avoid such issues from cropping up. Why does such things happen and one really goes into courts and all? I'll just give you one small example of this. So one example is, while fitting contact lenses, we tend to see the eye as a standalone platform for contact lens. Here is a surface on which I have to fit a contact lens, and don't think we even forget that there is a body attached to that eye. But the eye is part of whole body, and it is important to take a holistic approach to eyes, and we should look for other eye health assessments like ophthalmoscopy, visual fields, myopia, binocular. Professor Ramanjit had just talked about all that we can miss, and many other things. So we should look at the system as a holistic system of the whole body and not just as the surface of eye. The professional law as of today, the professional conduct, we are healthcare professionals instructed in the science of healing, expected to keep our knowledge up to date, and consent from patient is very, very important. This is where most of the problems occur in medical legal field. Patient's autonomy, that is the patient's right to know and decide about what is being done to the body during medical treatment, is well recognized principle of modern law. So we should not be just going ahead and doing things without even discussing and telling the patient what I'm going to do, which lens I'm giving to you, and what it's going to do to your eye, and what it's not going to do to you, and all those things. A doctor cannot proceed in the absence of a patient's consent. Consent of patient is presumed in every interaction between the doctor and patient. Presumed means whenever the patient walks into your clinic, it is presumed. It is understood that he has a consent, that is there to take your opinion. But in interventions and treatments, a separate written consent is required. where we have something wherein we are doing a procedure. So as of today, all this is there. The answer is that we must keep records, diagrams, images, etc. as far as we can. The simple rule in law is if it was not written, it was not done. So document everything, all things which you do with the patient. Keep secrecy of patient's information and database. Don't sell your patient database to any company for advertising and all. No adverse comments about other professionals should be made. And also, we are responsible for the substitution optometrists who may fill in our absence. So there should be no scare. We have rights also. So the rights are, number one, there can be no medical legal case if there is difference of opinion or diagnosis. If the result of treatment is not what was expected, we choose one option out of 2 or 3 or 4. If we administer any new medicines as per the protocol defined, the amount of fee we charge, all these things cannot have a case against you, because the law wants care and not cure. What is expected by law is that you did take care. They are not concerned whether cure came in or not. If you have taken care, there'll be no case. So legal defense, which is available to us after the commission formation, this is called Bolam's test, which is a case which was in 1957, Bolam versus Friern Hospital in Britain, but Indian courts honor it. All over the world, practically this is quoted. It means that if someone has done an act and that is counted to be a little substandard, it will not be considered to be compared with the best person in that field or a specialist. It will be considered with the average practitioner. If an average practitioner would do, suppose an association says the optometrist has adopted a practice that is considered proper. That's it. It's a reasonable body of practitioners. Out of 10, 9 people say, I would have done the same. And that's it. That's all what is required. We don't have to be comparing with the super specialist that he could do it better than you. No, an average practitioner only. So we have certain therapeutic privileges after the commission formation. That is IPC, Indian Penal Code section 93 tells us, suppose I tell someone, oh, you have keratoconus, and that man faints. And he says, why did you tell him like that? He fainted, so I want to sue you. No, communication made in good faith is protected here. And similarly, other protections are there. We may do certain things with consent in good faith. We may do without consent in good faith. We may do it with the consent of an elder when the child is below 12 years of age, or we may be doing certain act when we are compelled. There's someone keeping a gun on the head and say, fit this lens to this patient. Whatever you do, well, there you are all protected there. So all foregoing aspects of professional law are to be followed, and these are also enforced by clinical establishment, which is Registration and Regulation Act of 2010. So far notified only in union territories and few states, but primarily professional law will be guided by the Allied and Healthcare Professions Bill 2020. These are just a few points in law. Knowing them is better than not knowing them. Let us look at law as a friend and how I can help. I'm an optometrist first and advocate later. So I'll be happy to extend free advice on legal matters, whatever it may be check bounce, trademarks, labor issues, writing of will, or any other matters. Well, you are welcome to contact me for any further queries. My numbers are displayed here. You may record it, take a screenshot, whatever. So there we are. Thank you very much. And thank you. Any questions? I'll be glad to answer.
I would like to ask, according to you, sir, what would you like to advise the budding optometrist?
Budding optometrist should just follow the basic system which is there. Budding optometrist, either in internship or later, should work with a senior for a few weeks or few months and see how the system actually works. It's like someone says, put a little fluorescein in the eye, and what is little mean? That only you get to see when you practically work. So things like that will happen only when you are assisting someone or helping or are working with someone. Similarly, in spectacle lenses, there are tolerances. How much are the tolerances? Thickness, what is called thick, what is called thin. what is commercially available in spectacle, and we say take a high index. High index can mean many things. High index can be different indices. High index can be whether it is aspherically created, is the optics better at the periphery, so many things. And all this commercial availability one gets to know when you work with someone, and with that you'll be able to really launch yourself very well.
Okay, thank you, sir. Thank you so much.
Thank you. Good luck to everybody. Thank you.
Thank you.
Now let us move for our next topic, which is presented by Ms. Mayuri Deka. Ms. Mayuri Deka is currently Assistant Professor and Academic in Charge at Trigle College of Optometry, Jorhat, Assam. She is into the profession of teaching since 8 years, guiding and mentoring students as well as interns. She has also written many optometry articles published in the Indian Optician. I'm honored to invite you to speak at the topic Behavioral Optometry Overview. Ma'am, please enlighten us with your kind words.
Over to you, ma'am.
Over to you, ma'am.
Hello, everyone. Hello. Am I audible?
Yes, ma'am.
And can you, is my screen visible?
Yes, ma'am.
Okay. Okay, hello everyone. I hope everybody is well, and I'm very sorry for the technical issues I had. And I'm glad I could speak on this topic of behavioral optometry, which is not so much talked about, but it is a part of optometry. And I would like to thank the entire organizing team of AIMS that they chose me for this. So let's get started. I would begin with introduction, then continuing with origin, goals of behavioral optometry, benefits, research, and general acceptance. Introduction. Behavioral optometry, also known as optometric vision therapy, is an individualized treatment program designed to improve visual function and performance. Behavioral optometry considers our vision in relation to our visual demands such as reading, computers, and learning to read and write to ensure our vision is working easily and comfortably. So behavioral optometry, even though it is not spoken about much in classroom teaching, but it finds its place, and the behavioral optometrists, they do take a very holistic approach when it comes to assessment and treatment of patients. In addition to eye health and sight, the person's ability to easily direct, track, or fixate using the two eyes together as a team, and the process of visual information. So these things are assessed by a behavioral optometrist. This also referred to as visual training or orthotics. It is an established medically necessary therapy when prescribed by an optometrist. Origin: behavioral optometry traces its roots to the writings of Dr. William H. Bates, who was an ophthalmologist. Bates began writing in the 1920s about the alternatives to the use of corrective lenses. He believed that many physical and emotional stresses caused vision problems and that alleviating these stresses could improve vision. He noted that modern humans spend an inordinate amount of time doing close work, such as reading, while the human eye may have been originally adapted for distance vision. So initially, it was thought that the human eye was originally adapted for distance vision, but with humans tending to do more of near work and close work, such as reading and spending time on nowadays, especially on the mobiles and technology which is at hand. So because of that, the human eye, which was initially adapted for distance vision, now it needs to be adapted for near vision as well. So he devised a program of eye training that allowed patients to gradually improve their vision without glasses. Behavioral optometry care involves more than just measuring your eyes on the distance chart. It is an approved treatment modality for disorders including, but not limited to, measurement of focus and eye coordination function problems, which affect visual comfort and performance when reading and writing and using computers. Measurement of distance focus, especially if there are symptoms of difficulty looking up clearly from computers, or blurred distance vision, which could be short-sightedness, beginning to develop as a result of more time on computers and less time outside. Assessment and treatment of lazy eye and turned eye using spectacles and sometimes vision therapy. Assessment and treatment of development of tracking eye movement abilities for reading fluency. Assessment and treatment of child's developed skills of vision, perception, or processing to ensure these abilities are normally developed for their age and are affecting their ability to learn to read and write and to read at age level and achieve to their potential. Assessment and management of visual issues associated with health and neurological conditions such as stroke and head injury, etc. Most people who visit an optometrist know that an eye health problems will be detected and managed and that glasses or contact lenses will be prescribed if indicated. That picture may be incomplete because there are visual conditions that could be managed by optometric vision therapy of behavioral optometry. This therapy enables an individual to learn more efficient ways to perform visually. It is an art and science of vision care that complements the prescription of spectacles, contact lenses, and the treatment of any eye disease. Goals of behavioral optometry. The goals of behavioral optometry are to prevent vision and eye problems from developing or deteriorating, to provide treatment for vision problems that have already developed, example, eye turn, short-sightedness, etc., to ensure the visual abilities needed in the classroom, workplace, when playing sport and using computers are developed normally and working well. Recommendation of a behavioral optometrist. Advice to prevent or reduce the possibility of eye problems developing, appropriate prescription of glasses, vision therapy to improve vision function and visual processing development, the use of tinted lenses were indicated by specific testing for certain conditions such as migraine and concussion. So what are the benefits of behavioral optometry? The benefits of behavioral optometry, which include improved visual information, processing and ability to sustain visual function over time, are as applicable to the child in the classroom as they are to the adult using a computer or reading a book. More often, individuals have no adaptation that decreases their avoidance of visually demanding tasks or an adaptation that decreases their performance. Behavioral optometry also facilitates appropriate visual development and serves as a component of the multidisciplinary effort following stroke or head injury. Research and general acceptance. Though behavioral optometrists are definitely a minority within the field of optometry, a body of research supports their methods. This can be found in professional journals such as Journal of Behavioral Optometry and Journal of Optometric Vision Development. Many patients and practitioners have written of their ability to function without glasses and overcome learning disabilities through behavioral optometry. Vision therapy devices and exercises to improve eyesight. A non-invasive method called vision therapy is popularly used by many optometrists to manage different eye conditions. This technique involves exercises that can help the working relationship between the neurological and visual systems. The very common is pencil push-up therapy. This eye exercise aims to correct binocular visual disorders like strabismus. Computer-assisted vision therapy, which involves activities that stress vergence, eye movements, accommodation, and visual information processing. Prism or lens fixation. This exercise teaches your eyes to see things and persons that may be at a close or nearby distance. Patching. In myopia, wearing an eye patch on the stronger eye will reduce stimuli, which will force your brain to accept the weaker eye's visual cues. Vision rest. Individuals who spend lengthy periods focusing on computer screens should follow the 20-20-20 rule. That is, when we are looking at any screen for 20 minutes, we should fixate an object which is 20 feet away from us for 20 seconds. These are my references. Thank you. Any queries? Hello?
Yes, ma'am.
Hello, any queries?
No,
Was
ma'am.
I audible?
Hello. Yes, ma'am.
Yeah, well,
Thank you so much, ma'am, for your
thank
wonderful
you.
talk. Okay, ma'am. We will taking a short break. We will right back soon.
Hello. I'm audible now, right? Okay. Hello. I think it's vikas.chaturvedi@viscometic.com. I don't. I'm in hall B, I believe. मेरे को जो लिंक दिया था उसने यार, मैंने देखा नहीं है कौन सा है वो, बट ओके, इट्स फाइन ना. ओके. कहाँ चला गया? स्क्रीन शेयर कर रहे हैं. ठीक आ रहा है. कुछ नहीं दिख रहा. स्क्रीन नहीं आ रहा. स्क्रीन नहीं आ रहा. Please move this window away from the shared application. The screen is paused. Resume. अभी आया? आ गया. बड़ा विकेट. हेलो. हेलो. No response. बोल के निकल जाओ.
Welcome. Good afternoon, Vikas sir.
Hi sir. Good afternoon.
कैसे हैं? बढ़िया.
Yeah sir. Very good sir. How are you sir?
बढ़िया. First class. Good to see you on conference.
So my voice is clear sir to you? हेलो. अच्छा. क्या करना है? मेरा लाइव पॉज हो गया ना शेयर. चल रहा है तो आपकी आवाज भी आ रही है. आवाज आ रही है ना, बट पीपीटी भी तो चेंज हो रहा है. देखो अभी हुआ ना. पहले
A very good afternoon to everyone. Now we have our sponsors, Mr. Vikas Chaturvedi, the director of V Square Medtech. So please provide us our intro of your company. They are the gold sponsors for our AIMS Optometry Explorer 2021 and has served such a helping hand in these tough times. Thank you so much, sir. Over to you.
No, you are not. Yeah. Hi, good afternoon, everyone. So am I audible? Is my voice clear?
Yes, sir.
Okay, Sumit. So can I know who are the panelists for me? Hello, Sumit.
So we have all the audience waiting for you, and Anand Modi sir has joined us.
Okay, so he's our panelist, Anand Murthy sir. Okay, fine. So I will start with I will share the screen now. Wait a minute. So my screen is visible to everyone?
Yes, sir, visible. This is Anand Murthy, sir.
Hi, sir. Good afternoon.
Good afternoon, sir. How are you? Please proceed.
So, okay. So my it's a sponsored talk. So I actually I'm working with V Square Medtech Private Limited, and we are basically working in a bridge of ophthalmologist and optometrist. So all the products which we are have in our armamentarium are actually for optometrist under the guidance of ophthalmologist. So what are the products and services we are offering? So we have specialty contact lenses, we have dry eye division, we have low vision devices, and very recently we have launched computer aided vision therapy. So I will go one by one. I will discuss a little bit about all the products, not in a little bit brief about all the products, and try to make you understand how we actually position these products in today's optometry practice. So if you talk about specialty contact lenses, so we have the corneal ectasia lenses, we have Accucone K, we have Keracare lenses as a scleral contact lenses, we have myopia control lenses from GOV in orthokeratology lenses, as well as soft ortho lenses for myopia control. If I talk about the scleral contact lenses, so the brand name is Keracare, and we have all the modifications with our lenses. We can do all the modifications required for scleral contact lenses. The dia extend from 15.9 to 20.1 millimeter. Previously, we have dia till 19 millimeter, but now we have till 20.1 millimeter dia. So what is how Keracare scleral contact lens is different from other contact lenses available in the market? So we have a very patented technology known as Hydra PG coating. It's a Hydra polyethylene glycol coating, which actually helps for high wettability of the contact lens surface, and it increases the water surface retention, which helps patient to have a better comfort, long time wear, and also reduces the dry eye. Accucone is a lens which is just like a rose K design lens with AccuLens advantage. What do I mean by AccuLens advantage is that we can give you a different material, which is a decay of 140 dk by T also with our lenses, and which gives you a better vision, comfort, and of course the AccuLens material. So this is about our scleral lens details. So as I say that now we can have a diameter range from in scleral contact lenses ranges from 15.9 to 20.1. It's 20.7, and power we can provide from plus minus 30 diopter. We can also give a cylindrical power till -5. So this cylindrical power is basically the front surface toric. We know that in specialty contact lenses, hard lenses, most of the time because of the saline, we mimics the anterior surface, we actually cover the anterior surface. So most of the astigmatism caused by keratoconus or other ectasia is actually resolved. But when it comes about the posterior surface astigmatism, which is also very common in high keratoconus patient, so we can provide a cylindrical power till -5 diopter. So this is a specialty. This is a USP of our lens. Apart from that, we also give multifocal scleral contact lenses. So if we talk about the technology, we have front toric, we have multifocal, we have double slab of technology, we have toric haptics and aspheric also. We also can give you a truncation if required and with notch also. Little bit more about our scleral contact lens technology. This is a very unique in the sense that, as I already told you, that we can do all the modification which is required for scleral contact lens fitting. Because whenever we talk about scleral contact lens, so the more we are going towards the sclera from cornea, the more modification is required. And for that, we have a very high-end technology known as CAD technology, by which we can do all the modifications. Whatever modifications required in any zone, we can do all the modifications. This is the same tangible Hydra PG coating. Now about myopia control. So if you talk about myopia control, today, when we started talking about myopia control in early 2018, maybe January sometime, we started talking about myopia control in India from V Square. We faced a lot of challenges. Challenges mean to say that ophthalmologists or even many optometrists also, they don't know what is myopia control and how myopia control works. So as we know that in India, the ophthalmology market or even the optometry market, if we talk about high-end products, is driven by ophthalmologists. So we thought that we should go ahead with this technology and try to educate people, especially the ophthalmologist, about the myopia control. And initially, when we started talking about myopia control with the ophthalmologist, you will not believe, doctors were not ready to listen a single word, because they were very much maybe because of the previous articles, or maybe because of their experience, I don't know, but they were not very comfortable with orthokeratology word. But we didn't lose our hope. We started talking more to the ophthalmologist. We meet personally all the ophthalmologists, and then we also conducted few conferences in CMEs in coordination with the ophthalmologist. We also participated in All India Ophthalmology Congress. We participate every year. We can say after 2018, we are participating in each and every year where we are talking about myopia control to the ophthalmologist. So now, fortunately, what we have understood that doctors are also ready to listen, and they also want to know that how orthokeratology or other myopia control intervention works to control myopia. So now this is about the product. So we have all the ranges in orthokeratology. We have myopic lenses, we have the hyperopic lenses, we have hyperopic presbyopic lenses, we have post-LASIK orthokeratology lenses. And there are a few articles which supports that even orthokeratology, they have a special design which even works for a mild keratoconus. These are few patents by GOV. Globally, they have some around 18 patents worldwide. India also have a patented, we also got a patent for our GOV lenses. Now this slide is sold actually, but now we all have a patent in India also. In same myopia control, we have another lens, which is very, you can say it's a very beautiful lens in the sense that it actually works just like orthokeratology lenses, but it's a soft day wear lenses. So it's a soft approach for myopia retention. This is how the lens looks like. If you put the high molecular weight fluorescein, then you can see it's just like orthokeratology bullseye pattern. But it's actually not orthokeratology, a soft lens. We used to, the lens is for day wear, and it actually have a very good control and the study shows that the control is as good as orthokeratology lenses. So as I discussed that we were actually trying to work very hard. Right now also we are working very hard to convince people about myopia control. So there we also discuss about the decision tree for myopia control. Means what I want to say that when we talk about myopia control, so it's not only about orthokeratology. It's not only about soft multifocal lenses. It's actually more than that. So myopia control starts with the binocular vision. So any abnormal binocular vision will not give you the expected result for myopia control. So the first thing is that we need to take care of the binocular vision. We need to see if we can, by giving some exercises through vision therapy, if we can improve the binocular vision, then we can shift a patient to orthokeratology lenses. Otherwise, there is a decision tree which actually helps you to understand which particular intervention is required for a particular child. So these are the things which actually as a service provider we are doing. We are training on the protocols of myopia control to the ophthalmologist, to the optometrist. There are a few consent forms which is required to be signed by the patients or the parents with a follow-up criteria format. And of course, as a company, we are also providing the marketing materials to educate people, to educate the children and their parents about the myopia control. The second division which we are working on is on the dry eye. So we have both the diagnostic as well as the therapeutic devices with us, but mostly we are focusing these particular products in the ophthalmologic segment in the hospitals, because these products are a little bit costlier. And but I have something for optometrist also, or you can say we can use it, we can dispense it in our optical chain outlets, in our optical outlets. So I will discuss about that. But before that, I just want to highlight this point that over a decade, I think you all must be knowing this, that over a decade, the user of soft contact lenses is somewhere around 140 million. And fortunately or unfortunately, it is stable. So since a decade, the contact lens users are almost constant. But at the same time, if you see, the contact lens technology is evolving. So over a decade, we know that there are many high-end products available now. Many good materials are available, but still the market growth is not so much. It's stable, or maybe 5-10%, I don't know. So what is the main reason for that? So the main reason is that the dropout is somewhere around 70% because of contact lens induced dry eye. And if you say that its dropout is 70%, then that means if it is constant at 140 million, so that means that we are also increasing every year by 70%. The users are increasing by 70%, but at the same time dropout is 70%. So it becomes equal. So do you have any solution for this? So this is one article on the root cause of dryness in contact lenses, which clearly mentioned that because of the soft contact lenses, we can have Mabian gland dysfunction. And this Mabian gland dysfunction can cause dryness, and patients are a little bit uncomfortable, though they have a best material available, but they are uncomfortable. So if in this case, if we can give them some treatment where we can treat the Mabian gland dysfunction, then maybe we can increase the market growth for contact lens, soft contact lenses. Now, there is one more article done by TFOS International Workshop, where they also highlighted the same thing about the Mabian gland dysfunction, and they call it CLD. So can we prevent the dropout? We know that today we have a lot of material available, very good materials are available. We have a better modality. We are talking a lot about care and maintenance. But still we know the situation. So now this is about the home therapy, which actually can help us to reduce the frequency of mabion gland dysfunction in the patients wearing contact lenses. V Square has something to offer you. This is known as Mebo heating pad. So this heating pad is based on the far infrared heat, which generates heats in the iPad. And we have a timer, and there is a temperature regulator also. You set the time, you set the temperature, and wear it for 10 minutes, and it will help you to unblock the meibomian glands, which is being blocked by mebium. So once these glands were unblocked, lipid secretion will improve, and patients will have they can get rid of the dryness problem, especially the evaporative dry eye. That means that caused because of lipid deficiency, and the problem is because of the mabian gland dysfunction. So this is about our very it's actually we are doing very good in heating pad, especially in optical outlets. We are getting very good numbers, and I think you also should try. Unfortunately, this time we don't have we have a virtual stall, but you can contact us. We can give you more detail about this. You can try this with your patient, and you can see the results. Now, about vision therapy. So I think before me, Mayuru ma'am was talking about the behavioral optometry thing, and there she talks about the vision therapy also. So if you talk about vision therapy, and if you talk about vision therapy in India, so today vision therapy in India is all about what I have understood a little bit about vision therapy within a couple of months, you can say, because we have just entered in vision therapy market. So what I have understood that vision therapy is all about amblyopia and strabismus. But actually, that is not the actual scenario. If you talk about vision therapy, it is more, and it is beyond strabismus and amblyopia. It is more about visual information processing skill. It is more about hand-eye coordination, and it is more about visual thinking. So we have a software known as CAVT. This is from US, computer-aided vision therapy, where apart from, of course, we also do a therapy for amblyopia and strabismus with our software. But apart from that, we also talk more about the visual information processing skill, how you can develop the visual information. So there are a lot of exercises available in this software to develop the visual information processing skill. So this is all about my presentation, about my company profile. And if we have more time to talk, then I can open some other slides and we can discuss. Otherwise, I'm open for questions.
Hello.
So thank you.
Yes, sir.
Yeah.
It was a nice presentation, sir. Actually, I have a question. There are smaller dia lenses also in scleral lenses.
Okay.
So what's your say on that? Smaller dia means there are lenses which are 14.5 mm dia. That is smaller than your lenses. So would you like to say something about that?
So thank you for bringing this point, Anand sir. Actually, this is one of my favorite topic, because nowadays I'm actually trying to understand that how scleral lenses means what are the advantages of scleral lenses first of all, and what are the disadvantages of scleral lenses. So of course we all know that the advantage of scleral lens is that it is we can mimic very significant keratoconus patient. We can give them a better comfort with the scleral contact lenses, and we can also give them a better visual acuity, right? Stability is better with scleral contact lenses. But at the same time, there are a few disadvantages. Disadvantage mean to say that if the fitting is not proper, and if you don't know the technology behind any scleral contact lenses, then it actually causes a lot of problem in long term. Even problems like stem cells, limbal stem cells damage is also possible if you don't know about the technology of scleral contact lenses. So if I have to explain this in a better way, so just a minute. I will try to share one presentation. Okay, fine. Let me go like this only. So when we talk about scleral contact lenses, so scleral contact lens is actually a lens which is going to rest on the sclera. And if you see the anatomy of a sclera, so the anatomy of sclera is not as even as in at the cornea, means in the limbal part. So once we go behind the means once we go away from the limbus, the anatomy of sclera is very irregular. So what I want to say irregular mean to say that the temporal and nasal, both the surface is not same. Maybe we have seen that even 500 microns of irregularity is there from temporal to nasal zone. So we need lot of modifications. We need to do lot of modifications in a scleral contact lenses. And to do that modifications, we need a better technology where this technology can help us to do all the modifications. So now, so this is about the scleral contact lenses. So first of all, when we talk about scleral contact lenses, so let me go very straight with you that we need to know more about scleral contact lens fitting. It's not so easy as we believe. It's a very tough thing when it comes about scleral contact lenses. When we talk about 14.5 millimeter lenses, so we know that the average corneal diameter, or if you say white to white, is somewhere around 11.5 to 12 millimeter, right? So this 11.5 or 12 millimeter is the white to white, but that doesn't mean that limbus is till 11.5 or 12 millimeter. Because if you see and if you know a little bit about the anatomy of the limbus, so the width itself of limbus is somewhere around 2 to 2.5 millimeter. So now if you see the white to white or is somewhere around 11.5 or 12 millimeter, let's take 12 millimeter, and if you add 2.5, so it becomes 14.5. So basically limbus is actually extending till 14.5. And if you are resting a lens or at 14.5, so what will happen? So now, whenever we're talking about the, as I already say that the scleral contact lenses are meant for high keratoconus lenses, high keratoconus patient. So whenever, and the fitting philosophy of all scleral contact lenses, even for the lenses which is with 14.5 millimeter, is based on the sag height. So if we increase the sag, because if the stiffness is more in the cornea, so we have to increase the sag. We don't have any option. And as per the philosophy of scleral contact lens or this lens fitting, it's we need to have a vault of somewhere around 150 micron after 1 hour, means after settling the lenses. So just assume that a keratoconus is somewhere around 65 to 68 millimeter stiffness. The cornea is somewhere around 68 millimeter of stiffness, and in that case we have to take a vault of somewhere around 150 micron. And that 150 micron is at the tip of the cone. So apart from that, wherever the stiffness is less, so this vault will be more. It will be somewhere around 300, 400. And if you don't have a very good technology where actually we can make the vault very even manner, so that then in that case the vault will be somewhere 400 micron at some point of the lens. So what I want to say, the tear volume which is present inside the lens is too much. And what this tear volume will do? This will actually induce a pressure. And where it will induce the pressure? It will induce the pressure where the lens is landing. If it is landing on the sclera, let's say around 16 millimeter, then it's fine. But if it is landing at 14.5 millimeter, where you have the limbus, and at limbus we have the stem cells. So if a patient is wearing a lens throughout the day for 12 hours, and we are inducing a pressure for 12 hours, just assume what will happen to the limbus and what will happen to the stem cells. And that is is it for one day? No, it is for 4 years, 5 years, 6 years, long term. So basically, it will actually cause the limbal stems damage. And once the limbal stem cells are damaged, you know that what will happen to the cornea. And the best part is that whatever we are doing today, we are actually working with the compromised cornea. Cornea is already a compromised one because it's a keratoconus. It's already a compromised cornea. And in compromised cornea, we are putting all these things, put together, we are increasing the IOP, we are indenting the lenses at the limbus. So what will happen? Long term, of course, will be a very, very disaster. So I believe that that what I said means before putting a scleral contact is not only for comfort. Of course, it gives comfort, but when we are talking about scleral contact lenses, then we should know the anatomy of the eye first of all. We know how we are going to place the lenses, where it is going to sit, what will happen to the in the long term. So it's not only about visual acuity; it's about more. It's about many other things which we need to take care. So I don't know able to answer your queries or not.
No, it was beautifully described. Very good.
Thank you.
Means you actually wanted to say that scleral fitting is not just limited to achieving the best corrected vision. It's not also limited to best comfort. It's also means you also need to see the long-term impact of the scleral lenses.
Right.
That is where larger dial lenses are better compared to that smaller dial lenses.
It's not the better, sir. This is the only choice.
Only choice, yes.
If I have to say, then I say this is the only choice. When we have a significant keratoconus, if it is 52, 48, then of course we can go with 14.5 mm, because in that case the volume is not so big. So
yes, definitely.
Internationally also CSL is available. It's not like it's only available in India, but those are meant for mild and moderate keratoconus, not for severe keratoconus. And in India, we know the economy of India. Patients will go only for scleral contact lenses when they don't have any options, when they don't have RGP, when they don't have rose scale lenses designed. Then only they go for, because it's a costly lens. So in that case, I think we are playing with the eyes of the patient if you're going with the small dia lenses for severe keratoconus.
Okay, thank you, sir.
Thank you.
Any other question from anyone of the audience?
Yes, sir. We have a question for you, sir, from audience. Is there any complication on long-term use of orthoke lenses?
There is no such record, I think, for long-term negative impact of the orthoke lenses. The negative impact may be only short-term, like if the patient is not following the compliance, like in with any routine contact lenses, you need to follow the compliance, means the maintaining the hygiene. And the second thing that you need to tell your patients while prescribing orthoke lenses is, because these lenses are overnight wear lenses, so patient may rub their eyes during the sleep. So you need to tell them about not rubbing the eyes. That is the only complication that patient can get. If the patient rubs the eye very vigorously, then definitely you can get corneal like scarring. So you need to convince the patient or consult the patient for that. Long-term negative impact I have not seen or not read about.
Can I add up something in this?
Definitely, sir. Please.
Yeah.
Yes,
so
sir.
Whenever we're talking about orthokeratology lenses, so it's actually about myopia control. What is actually it is meant for. Now, of course, there is a complication with everything. Like even with all soft contact lenses, also there's some complications. And whatever I have read, I have understood that the complication of with orthokeratology lenses is somewhere around 10 times in 10,000 of years. So if a patient is wearing for 10,000 years, he will have a problem in interval of, means he will have a problem 10 times in 10,000 years. So now we can understand how less the complication is, but still there is a complication, no doubt. But my point is that if you are talking about myopia control, and myopia control, you know why we are doing myopia control, because we are actually trying to avoid the complications which is going to happen because of a larger axial length, like myopic degeneration, even retinal detachment is also possible, glaucoma, even cataract. So all these things can be avoided if you are going with the myopia control. And the complication of all this, whatever we have talked now, means all the diseases, is more than the complication which I have just mentioned, 10,000 in 10,000 years, 10 times. So we need to choose which one is more riskier. Is it this complication or the complication which is going to happen because of the axial length, higher axial length? Thank you.
Any other question from anyone?
Thank you so much, sir. Now this is a time for a short break. We will be right back at 2 o'clock. Thank you, everyone.
Okay.
Thank you.
Thank you,
everyone.
Thank you.
Okay, bye-bye.
Short break. We will be right back at 2 o'clock. वीडियो नहीं चल रहा यार वीडियो नहीं चल रहा ये वाला वीडियो नहीं चल रहा ना मैंने बोला सुमित को क्या बोल रहा है वो अभी सुमित है नहीं यहाँ पे तो वीडियो तो चल ही नहीं रहा करूं नहीं को करूं क्या बोल वाला
Good afternoon, everyone. I feel extremely privileged to invite Dr. Nupur Gupta, an eminent faculty at Dr. RP Center for Ophthalmic Sciences, AIMS, New Delhi. She has 20 years of teaching and research experience and has actively participated in various conferences. She has received various awards and national and international platforms. Her contribution in the field of dry eyes has been lauded both nationally and globally. She has more than 200 publications to her credit and is serving as an international expert to WHO. Over to you, ma'am.
Thank you. Thank you for the opportunity and congratulations on a very nicely conducted and organized workshop. Can you see my screen and can you hear me?
Yes, ma'am, you're audible.
Okay, thank you. So my topic today was to talk on primary eye care, taking into account both the ocular surface and the corneal disorders. So I will be taking you through some case presentations and also how is it relevant to primary eye care. So what actually is primary eye care? Where actually the optometrists and the middle ophthalmic personnel have a very important role to play. So it's a frontline activity providing care, and so that a promotive or a preventive kind of a healthcare system which does not lead to a serious medical issue. Why is it very important to us? That because India actually ranks and contributes to around 1/5 of the total burden of global blindness and visual impairment. And why it will, if we have a very strong primary eye care system in the country, we would be able to actually make the primary eye care services accessible and available to everybody. And of course, it will be affordable when we provide it through the vision centers. So typical vision center, we have a lot of vision centers run through RP Center or Indian Institute of Medical Sciences, and it provides quality care in visual acuity estimation, refractive error correction. Also, it will take into account the needs of people who have diabetic retinopathy, glaucoma, corneal opacity. So if you can see proper refraction, a non-contact tonometry, fundus evaluation, a non-mydriatic fundus imaging, which is standard of care and is planned to be provided at vision center level by the Ministry of Health and Family Welfare. So, and this on the right side that you see, the yellow document is a World Report on Vision, which was launched last year by the World Health Organization, which takes into a component of integrated primary eye care to be actually given accessible to the people with health services. So if you see this table, it is very comprehensive to see that what all activities can occur at the vision center or the primary eye care center level. So refractive error, cataract, diabetic retinopathy, glaucoma, all can be diagnosed. Some may need to be referred, but the preventive and the promotive steps for a lot of diseases and a referral system for all the diseases can be done. So what I will be dealing today will be an ocular surface disease, which is prominently the dry eye disease, and the other corneal opacification, which are basically the loss in corneal transparency, which is a manifestation of usually all the corneal diseases. So if you see a morbidity profile which is present in the vision, this is data around 2 lakh patients which are being served through the community ophthalmology department. Most of it, as you see, is basically refractive error and presbyopia, followed by cataract. Conjunctivitis is an important component, so you should be able to diagnose wherever you are and actually treat it at that level and refer whenever you think there is a need, if there is a visual deterioration. And of course, corneal opacity is an important component to be referred for further management. So coming on to conjunctivitis, which is very, very common, they say actually 1 in 3 people will have conjunctivitis, and you actually will come across 2 types of conjunctivitis in your practice. One is bacterial, the other is viral. Viral being very common, it is known as eye flu. So I will be, for understanding conjunctivitis, you need to know what all are the parts of the conjunctiva. So if you see here, if you see this red line, the dip here is the fornis. So that is a fornicial conjunctiva. The conjunctiva that is in contact with the globe, with the eyeball, is the bulbar conjunctiva, and that with the on the tarsal plate, which is the inner side, and you invert the lid, then you see it, that is a palpebral conjunctiva. So the various manifestations of different types of conjunctivitis actually occur on these parts of the conjunctiva. So just for a very brief differentiation between conjunctiva and cornea, we know that cornea is clear, the conjunctiva is translucent, both have epithelium, but the goblet cells, which are important for the ocular surface health, that is the which is basically contributing to dry eye disease, is actually present in the conjunctiva. And the nutrition for the conjunctiva is from the conjunctival vessels and the tear film. For cornea, it was from the tear film as well as from the aqueous in the anterior chamber. So coming on to bacterial conjunctivitis, you have a multitude of clinical presentations. They can be acute, they can be chronic, depending on where and what is being affected. So there can be a membrane, there can be follicles, there can be papillae, and the etiology is also different. So allergic conjunctivitis usually will have only papillae. If you have infective, you may have follicles or you may have discharge. So, and these are the causes cause conjunctivitis. So this is a clinical picture of acute mucopurulent conjunctivitis. You can see the discharge, which is very purulent. There is a congestion, but the cornea is absolutely clear. See, the patient will present to you with some discharge, matting of lids, unable to open their eyelids in the morning because of the matting and the discharge, and foreign body sensation. Maybe they would also have some vision deterioration, but is usually rare. They would have blurring because when the discharge comes in front of the visual axis. Then you could have a pseudomembranous conjunctivitis, where you have a formation of a membrane. The difference between a pseudomembrane and a true membrane is when you peel off this membrane, if you have bleeding, then it's a true membrane. A lot of bacteria cause pseudomembranous conjunctivitis like Corynebacterium or Streptococcus. You also have it commonly in adenoviral conjunctivitis. This is the second most common conjunctivitis, and this is the conjunctivitis that you have when you have a seasonal flu, and then a lot of people will have adenoviral conjunctivitis. There, you should not be giving profuse antibiotics. Here, you just need a prophylactic antibiotic, and lubricants is the mainstay of treatment, and it will go off, it resolves, though it may be accompanied with some preauricular lymphadenopathy, or it may progress to corneal involvement. The diagnosis of adenoviral conjunctivitis is purely clinical. For finding out which epidemic strain is causing the adenoviral conjunctivitis, you may go in for a PCR or a serology, but it's usually not necessary, and they respond to treatment with carboxymethylcellulose 1%. In addition to that, when you have, if you see this cornea, you have these small opacity. These are known as subepithelial nummular infiltrates. When they involve the visual axis, you need to give steroids, but this should be monitored very well because long use of steroids has its adverse events of getting glaucoma or steroid-induced glaucoma. So they should only be given when the visual axis is involved, should be tapered, or if the recurrence rate is quite high, then you may try giving an immunomodulator like cyclosporin or tacrolimus, and then wave off these steroids and so they also decrease the recurrence rates, because steroids, they are known to increase the recurrence rates of the corneal involvement. The other conjunctivitis that you should be aware of is allergic conjunctivitis. They are usually associated with other allergic manifestations of the body like rhinitis or excessive sneezing. Here, I have placed two pictures. The top one shows the follicles. You can see they're sago grain type follicles, white center, and in the picture below, you can see the flat top papillae. So papillae are actually a manifestation of the allergic conjunctivitis. If you also, there is a seasonal conjunctivitis usually seen in young boys and girls. It is known to manifest at around 5-6 years of age, then becomes episodic with each spring season in March or October. It's also known as spring catarrh. It usually comes and goes with seasonal variation. So here you need to treat again with cold compressors, anti-allergics, and they become chronic. So with excessive rubbing, they also may manifest with keratoconus. So that you have to be very careful. You have to advise the patient with lubricants and avoid rubbing of the eyes. And whenever they feel like rubbing, they should be putting the lubricants, and anti-allergics have to be given. Along with that, you may give a short course of steroids, and again, cyclosporin or tacrolimus if longer duration of steroid use is needed. Then coming under an important manifestation of actually an infective manifestation, which is trachoma. The active trachoma is caused by Chlamydia trachomatis. Why is it so important for us? Is because it's the leading infectious cause of blindness globally and an important cause of corneal blindness. So it is known to occur in places with poor environmental and personal hygiene. The manifestations are described as fisto, F standing for follicles, then inflammatory reaction, scarring of the tarsal conjunctiva, then trachomatis trichiasis, and corneal opacity. So here in these pictures, you can see the various manifestations of trachoma. Here you can see the follicles on the everted upper lid. You can see numerous follicles. So this patient has an active trachoma infection, which comes under TF. This patient actually, you can see the Herbert pits. These are degenerated follicles at the limbus. This patient has actually got a pannus. Pannus is basically vascularization, which comes into there's conjunctivalization of the cornea, and there may be a little limbal stem cell deficiency. This everted lid shows you the fibrosis and the contracture of the tarsal plate. So this actually leads to development of trichiasis. So there's inturning of the eyelashes because the lid is shortened. And here you can see a very prominent arch line. Again, this everted lid shows a very nicely arch line as if it is drawn by the hand. And this patient actually has the stage of TT, which is trachomatis trichiasis. They're touching the globe. There's a component of meibomian gland dysfunction we'll be discussing shortly. And these are the Herbert pits. So this is a chronic sequelae of trachoma. So why is trachoma a public health problem? There are two issues. The GET 2020 is a WHO launched program where they had envisaged that global elimination of trachoma would occur by 2020, but it's still ongoing. They have achieved a lot, and they define elimination as less than 5% of active trachoma infection in 1 to 9 years of age group, and the sequelae, that is the trachomatis trichiasis, as prevalence of 0.1% in the general population. So safe strategy, you should know what is safe strategy that is documented by the WHO for decreasing the prevalence of trachoma. S stands for the surgery of the upper lid. So you can do trichiasis as optometrists. So you can decrease the corneal opacification and hence prevent blindness due to trachoma. Also, you have to do an entropion correction so that the lids do not touch the eyeball and do not cause corneal blindness. A is for the antibiotics to treat the Chlamydia trachomatis infection. So if you treat the infection, there is no scarring because of the repeated bout of infection. The scarring occurs, and scarring causes the trachomatis trichiasis, and the trichiasis then causes the either corneal abrasions and corneal opacities. and contributing to corneal blindness. And then the other contributory factors in the safe strategy is the facial cleanliness and environmental modification. This also decreases the chances of infection. Then the other request for me to include was a dermoid. So dermoid is a very simple kind of a teratoma. Basically, you have an elevation at the limbus. It's a common location. The management is very simple. You have to excise. Either you can just do a conjunctival advancement at that place, or if the lesion is deep, after removal of the dermoid, we can place a corneal graft and suture it or secure it with glue. This is another patient with a dermoid. You can see the hair-like structures over the dermoid. You should know that there can be a conjunctival cyst formation within, like you can see the edge of the contact lens. So due to constant rubbing and friction or trauma, you can have formation of conjunctival cysts. They do resolve if you remove the inciting cause. Then you should know what is a pincicula. It is an elastotic degeneration. It's usually associated with ultraviolet radiation. So you have to prescribe UV protective measures to the patient who's concerned, who presents to you with pincicula, and also give lubricants, because when you give lubricants, it also washes off the other allergens and the other constituents that may lead to accumulation of particulate matter, which leads to formation of pincicula and also pterygium. So pterygium is basically a wing-shaped inflammatory fibrovascular growth on the conjunctival surface, which may actually encroach on the cornea, and when it encroaches on the cornea, we have to remove it surgically. So there's no medical treatment for it, and surgical excision is only indicated in few circumstances. One, when it is cosmetically needed by the patient wants it, or the more important indication is that when it causes astigmatism or encroaches the visual axis and decreases vision. So just to put into picture, there can be a pseudopterygium which forms after trauma or chemical injury. It basically occurs due to epithelial defect that occurs in chemical injury, and there the conjunctiva grows and attaches itself, and this also can be removed surgically. So now coming on to dry eye disease. So for dry eye disease, there's a DEWS workshop which was held, and various definitions of dry eye disease have been put forward by the dry eye workshop, which DEWS, which stands for dry eye workshop. So the DEWS 2 workshop, which was held in 2017, came with a central concept of loss of homeostasis of the tear film, which may be due to whatever reason, maybe inflammation or neurotrophic. So the way the dry eye definition has evolved has increased our understanding about dry eye disease. Initially, we only thought of dry eye disease as a decrease in tear quality or change in tear quality or a decrease in tear quantity. Then they gave a concept of dysfunctional tear syndrome, that is, the tear film is not functioning properly. But with the evolution of DEWS, we revised the definition, taking into account the multifactorial nature of dry eye disease, that it is related with inflammation and increase in osmolarity of the tears, and there could be ocular symptoms which are important, along with the neurosensory abnormality. So the definition that was put forth by the DEWS 2 task force was that dry eye is a multifactorial disease where there is a loss of homeostasis of the tear film. It is accompanied by ocular symptoms in which tear film instability and hyperosmolarity play an important part. So just to summarize, we can, in a patient of dry eye disease, you can have an asymptomatic patient or a symptomatic patient. An asymptomatic patient is one who does not have any symptoms but has signs. So this could be one because of the neurotrophic component, or when you have a symptomatic patient, we need to triage it to see what is the cause of the dry eye syndrome. So here the dry eye workshop also looked into the etiology and the management of dry eye disease. So it actually gives you a risk factor analysis. What is the reason, whether it's a local ocular cause, whether there is a surgery, or there is an autoimmune or systemic cause which is contributing to dry eye disease. When you have a patient who is young and does not have meibomian gland dysfunction, either due to computer vision syndrome or due to digital device use, then you should look for causes which are systemic in nature, because more than 40 plus, we know that dry eye is prevalent. But now, if you see a patient who has severe dry eye disease, there is no other inciting factor, then you should work up for a patient for autoimmune disease like rheumatoid arthritis, Sjogren syndrome, and accordingly also then do the various tests for dry eye syndrome to actually see whether the patient has evaporative type of dry eye or aqueous deficient. Because the management is totally different. One type of management will not work for the other. So you have to be very careful in assessing what is the cause and how to treat. So patient history is a very important component. Whenever a patient presents to you with dry eye symptoms, which could be itching, burning, foreign body sensation, blurring of vision also, they may even experience increased watering. So that also you cannot think that, oh, he has increased watering, he will not have dry eye syndrome. So then you do take an ocular history, whether there's contact lens usage, there has been a recent refractive surgery, cataract surgery, any kind of surgery. When there is a loss of nerves or the nerves are cut, you will have a dry eye syndrome. And a medical history, as I said, was very important. So how do you look for dry eye disease? You do a slit lamp biomicroscopy, you look for corneal xerosis, you may have an inflamed conjunctiva. Also, you look for the tear meniscus height, which you can actually see clinically and also by various equipments we will discuss further. There would be a decrease in the breakup time. There could be filaments or erosions. Importantly, you have to see for the eyelid disease if there is a meibomian gland dysfunction or some mucous strands on the corneal surface. So the recent advances in diagnosing dry eye have been actually an effort towards moving into non-invasive tests. So you can do a tear film analysis through the tearscope or the ocular surface analyzer. A meibomian gland analysis can be done by the OCT, where you basically any equipment which will give you infrared radiation can pick up, so even ConfoScan will pick up the meibomian gland orifices and the acini structure. And you can assess the tear film meniscus and the volume through anterior segment OCT, the TMH is measured, and also by strip meniscometry. So this is the lippy view where you can see, you can measure the lipid layer thickness, and also you can do a dynamic meibomian gland function assessment. Meibomian gland analysis is basically you can do with this is a picture which you can see the gland acini. So it's very important for some, especially in cases with contact lenses where you have a loss of the acini, or when you are given therapy for meibomian gland dysfunction, when you want to monitor the therapy, how the meibomian glands have changed with therapy. So tear meniscus height, as I said, you can see between the and measure the height. And the normal height is between 2.2 to 0.5. It is less, then you have an aqueous tear film deficiency. Then there is a platform which gives you an integrated analysis of all the layers of the tear film so that you can assess. So it will measure the tear film height. It will also measure the non-invasive breakup time. Usually in a clinical setup where you have a slit lamp, you do a breakup time by instilling fluorescein. And whenever the first dry spot occurs, you take that as the breakup time. But that fluorescein and any other thing that you put in becomes invasive. So here you have a placido disc which is shown onto the cornea, and whenever there is a disruption of the lines of the placido disc, that is actually the breakup time for that tear film. And you can also measure the lipid layer thickness by interferometry. And also then you, when you invert the lid, you can see how the meibomian glands, both for the upper lid and the lower lid, how much is the meibomian gland loss. So here you can see in pictures A, the meibomian glands are, you can see the ducts, they are well arranged and not lost. But in the picture D, you can see they are lost. So that is how you pick up meibomian gland loss. And the platform actually gives you a complete analysis on a single page, and this also is available for follow-up visits. So it's easier to explain it to the patient and also to see how the things have changed with your management. Just to complete the ocular surface staining picture for dry eye disease, this is the fluorescein staining where the patient has inferior corneal staining with fluorescein. Rose Bengal stains the dead and devitalized cells, and so it is more sensitive for staining for the conjunctiva. And this is a lissamine green staining, which is also a dye used to assess dry eye syndrome. This picture, as you can see, is actually a patient with filamentary keratitis because of severe dry eye. So here you should first give a copious amount of lubricants, a non-preserved carboxymethyl cellulose or any lubricant, 2 hourly, or if the patient does not respond or has filaments left over, then they could be removed. They could be picked up by the McPherson forceps under local anesthesia. Then if you can see this patient on the left, you can see the LASIK flap and is presented with a post-LASIK dry eye. You can see the corneal xerosis and the pattern that is picked up on the corneal surface. Then if you see these pictures, these are pictures of meibomian gland dysfunction. They have some corneal pathology, but if you see the lids and concentrate on the lid margin, that is very important. This, on the first picture, you can see a foamy discharge. Frothing is a component of meibomian gland dysfunction. Here you can see there's a capping of the meibomian glands and plugging, or then there's a formation of a meibomian cyst. So there, basically here, the glands have been plugged with the mucus secretion. And again, there is a meibomian gland here, gland atrophy can be seen and a frothing. And also you have lid margin telangiectasia in meibomian gland dysfunction. Another picture where you can see a lid margin keratinization because of the chronic meibomian gland disease and the blepharitis and that you can have with meibomian gland dysfunction. So the treatment for all this is actually a good warm compresses. So either you can have thermotherapy through the LipiView, or you can just prescribe masks or hot compresses to the patient, along with antibiotics like doxycycline, topical antibiotics, and lubricants. And this patients will resolve. And apart from this, lifestyle modification for computer vision syndrome. In young patients, when you have meibomian gland dysfunction, you have to tell them that they have to consciously blink their eyes and take breaks in between so that the secretions don't get blocked. And with the blinking, with conscious blinking, the meibomian gland dysfunction will revert. This is another form of severe dry eye, which I wanted to show you. This is a patient of Stevens-Johnson syndrome. Ankyloblepharon has occurred, meaning the palpebral aperture is shortened, and a severe keratinization with loss of lashes. So coming on to the cornea, this completes our discussion with the ocular surface. Corneal opacity is the most common and important thing that you'll pick up in a primary eye care setting. So you should know when there is a loss of transparency, you should know the causes for corneal opacification. So this was a study conducted in rural Gurgaon, and it is the largest epidemiological study on corneal disease worldwide. It involved around 13,000 patients and had a 94% response rate. So in this study, we found that the pterygium-associated corneal opacity was the most important cause, followed by trauma and infective keratitis. So these are the three things that you should know how to diagnose and maybe refer at the vision center level. The important thing to note here is that the blindness that was contributed by corneal dystrophy and degenerations, trachoma, and bullous keratopathy following cataract surgery. So the quality of cataract surgery needs to improve, and this is an important cause of corneal blindness in our country. So just to recap for the applied anatomy, what you should know, that you all know that cornea is made up of 5 layers with the tear film there. Whenever you have a disruption of the Bowman's membrane, then you will have a formation of a corneal opacity. If you have a superficial abrasion, which does not involve the Bowman's layer, we will not have a formation of a corneal opacity. So accordingly, we need to treat the patient. In any case of corneal abrasion that presents to you, you need to give patients copious lubricants along with antibiotics and maybe patch the eye for a day. The figures on the right are to show you there's a normal eye structure, but what I wanted to see was the normal limbal stem cells. These are stem cells which are important for the regeneration of the epithelium. So whenever the limbal stem cells are disrupted, you will have corneal opacification. There will be vessels which will encroach on the cornea. So here you can see a patient of limbal stem cell deficiency. And this patient has corneal opacification. There's conjunctivalization of the cornea. When you look for limbal stem cells, they will be absent here. And actually, if you do an impression cytology, you will pick up goblet cells here. So goblet cells are absent in the cornea, but when conjunctivalization occurs, then you will have goblet cells on the corneal surface, and these patients are actually treated with a limbal stem cell transplant. Or a scleral contact lens may help these patients, but these patients you cannot take up for a keratoplasty without doing a stem cell transplant. Otherwise, it will fail because the stem cells are important for epithelial regeneration, and they will have a persistent epithelial defect if the limbal stem cells are not taken care of. So coming on to other corneal diseases that you should be aware of, this is a patient of hepatic stromal keratitis, where you will have a corneal opacification. Patient will present with photophobia and decrease in vision. So, and they have recurrent attacks. So the important point is that you have to decrease the recurrences. So you, in these cases, you have to refer these patients to the ophthalmologist. Another manifestation of hepatic keratitis is an epithelial form, where you see a dendritic form ulcer. So these are the dendrites which stain with fluorescein, and these also are treated with ointment acyclovir. Just to show that the dendrites of hepatic keratitis stain up very well because there is a dead or devitalized epithelial cells, and they stain, the outline is stained with rose Bengal dye. This is a geographic ulcer where the dendrites have coalesced to form a geographic ulcer. This is also a form of epithelial keratitis. Again, same geographic ulcer and with dendrites in a patient who was treated for viral keratitis by corneal transplantation. You can see the graft-host junction. This is the donor cornea, and it is sutured. There are 16 sutures which secures the donor graft to the host tissue, but there can be a recurrence of the hepatic keratitis in the donor tissue as well. So then, to complete the picture, you should know what is a corneal ulcer. It is infective keratitis, basically a breach in the corneal epithelium along with infiltration with epithelial infiltration of inflammatory exudate, and it can be due to bacteria, acanthamoeba, which is a protozoa, or a fungus, which is a common organism. Other organisms can also cause infective keratitis. So just to show you the parts, the things that are manifested in a corneal ulcer, this is the hypopion, which you can see the black arrow in the first picture, the infiltrate, and the epithelial defect. This is a larger corneal ulcer with a central corneal abscess, and the right picture actually shows you that there is a corneal ulcer with a lot of exudates in the anterior chamber. Just to complete the corneal workup, you should know how to make a corneal diagram. You have a color coding for the corneal diagram. So you can see these are the congestion, the circumcorneal congestion that occurs in a patient of corneal ulcer. Then you can see the thinning, which is shown, the epithelial defect, which is shown by green. The yellow is the exudates. So even the infiltration on the cornea and the hypopion is actually shown with a yellow color. Then another corneal disease which is important to us because we are in a temperate zone, and because of the ultraviolet radiation, we do get degeneration which is known as spheroidal degeneration. It is also known as climatic droplet keratopathy or CDK. This also will have to be treated if it is superficial by a lamellar keratoplasty, or if it is full thickness by a penetrating keratoplasty. This is on the right, you can see that there are elevations. This is the ASOCT picture, the anterior segment optical coherence tomography picture, which shows that the epithelium is raised, and you will need to intervene if you need to visually rehabilitate this patient. Now, to just complete the picture of all the corneal opacification, the causes that you have seen, these are various dystrophies. This picture actually shows the granular corneal dystrophy. And then you have lattice lines. So this is lattice corneal dystrophy. This is a patient of pseudophakic bullous keratopathy. You can see the bullae and corneal haze. This again is a picture of spheroidal degeneration. Then on the lower left, you can see a corneal keloid, which also leads, this will need to be removed, and maybe a lamellar keratoplasty will help this patient. The other pictures are of granulocorneal dystrophy, and the one on the topmost right is actually a limbal stem cell deficiency. Thank you. Any questions? I would be happy to take.
Thank you so much, ma'am, for such an amazing talk. Now I'm glad to invite Dr. Rebecca Deman, Assistant Professor of Ophthalmology at Dr. RPC AIMS, New Delhi. She has more than 48 publications to her credit and has written 7 chapters in books. She has also received Dr. T.P. Agarwal Trophy for Best Paper Presentation in DOS Conference. Over to you, ma'am.
Yeah, hello everyone. Good afternoon, ma'am. It was a very comprehensive lecture. It just brushed off my cornea and conjunctiva, the cornea knowledge actually. So, yeah. So just moving ahead from chronic cases like conjunctivitis and some acute cases ma'am has discussed like keratitis. So coming on to much more acute scenario like the ocular emergencies. So here we'll be discussing these ocular emergency situations in context of optometry practice. So it's quite a pertinent topic because once you're practicing, you will come across a lot of cases who will present you in a state of an emergency with ocular emergency. So you should understand by definition what an ocular emergency is. So it is an unpredictable occurrence of an eye condition that requires immediate treatment in order to prevent an irreversible loss of vision. So understand that it does not just include cases of blunt cases of trauma, but it can also include certain medical conditions like CRAO, like central retinal artery occlusion or retinal detachment. So, we'll be discussing just in brief about everything. So as an optometrist, what should be your role and responsibility? Well, most of these cases might present to you as the first point of contact. So what can you do? You can take appropriate history in such cases, assess the signs and symptoms, can do basic clinical examination like vision, pupils, measure the intraocular pressure, and on the basis of it, you can make, some empirical diagnosis. And if you feel it's an emergency, you can guide the patient by a quick referral to a relevant ophthalmologist. Like a keratitis will be referred to a corneal specialist, a retina pathology will be referred to a retina specialist, and if it's a case of a trauma, you would refer it to a center where there is a GA facility so that the patient could be operated under general anesthesia. But remember, don't do anything which is not within your expertise. Okay? So what are the signs and symptoms that should sound an alarm bell? So one, if the patient comes to you and says that he had some trauma in the eye. Second, he has symptoms of sudden decrease in vision or flashes of light and floaters. They can present with red, painful eyes. Pupils could be irregular in shape or the pupillary reactions are affected. If the patient has high intraocular pressures or certain scenarios like corneal ulcer, as Dr. Nupur has already discussed in the previous presentation. So injuries, they constitute the bulk of ocular emergencies. What type of injuries? It could be mechanical. Mechanical means it's caused by some metallic object or some heavy object like a blunt. So it can cause a blunt or a penetrating trauma. Then there could be chemical injuries. Chemical injuries you commonly see in Holi, where the harmful chemicals go inside the eye, or sometimes you would see, and in India very commonly you see it associated with line packet injuries. Thermal injuries you will see during Diwali with firecrackers. Then trauma can lead to orbital fractures. It can lead
Sorry
to
to interrupt,
disease.
ma'am. Sorry to interrupt, but your voice is not clear.
Okay. So maybe there's some problem with my internet, although, okay. Let me just check. Actually, is it still a problem?
Now, am I audible?
Yes, ma'am. That's clear.
Yeah. So yes, so it could be mechanical, chemical injuries. So you couldn't understand anything that I have told before? Something you were able to understand, right? So I'll carry forward from here. So it was orbital, it could be orbital bony fractures. There could be foreign body embedded in the eye. Okay. So just remember that in case of mechanical injuries, you should remember this Betts classification, which is your Birmingham eye trauma terminology classification. So know about it, that it divides your ocular injuries into closed and open globe. Closed globe injuries basically where your ocular coats are intact. So there is no breach in the ocular coats of the eyeballs. It could be in the form of contusion or a lamellar laceration. Open globe, as the name suggests, that there is a breach in the ocular coat. So it could be a globe rupture, or it could be a penetrating injury, an intraocular foreign body, or a perforating. So perforating injury is the one which has 2 points of two wounds. One is the entry wound and the other is the exit wound. So basically high velocity, like bullet injury, injuries, in such cases, the bullet tends to pass through and through the globe and giving rise to two wounds. Okay. Then the patient can present. So what are the DDs of sudden or severe loss of vision? It could be, well, anything that affects the visual axis, starting from keratitis to uveitis, or it could be something lying in the posterior, like a posterior uveitis or retinal detachment. Then it could be optic nerve disorders like anterior ischemic optic neuropathy, the occlusive venous or arterial occlusion like CRVO, CRAO. Optic neuritis can lead to sudden decrease in vision, but all these optic nerve pathologies will have a relative efferent pupillary defect associated with it. Now, vitreous hemorrhage, retinal detachments can lead to sudden decrease. Now, another important cause is a occipital lobe infarct. So if there is an occipital lobe infarct, your eye examination is going to be absolutely normal. The pupils are going to be normal. So you might have to differentiate such patients from malingering, that where the patient actually has some problem or it's just a case of malingering. So one, you can do a VP. VP will help you assess the status of the occipital lobe, and neuroimaging definitely helps you confirm the diagnosis. Like you would see this large area of infarct involving the right-sided occipital lobe. Flashes of light you can see in cases of PVD, posterior vitreous detachment, or retinal tears and detachment. And this happens why? Because your vitreous is causing traction on the retina. Optic neuritis, you will see photopsias, but in that you will also have an associated RAPD. If there's occipital lobe infarct, sometimes the patient can complain of visual hallucinations in the form of flashes and floaters. So remember, all these things will need a dilated fundus examination. And if everything is normal, think of an occipital lobe involvement. So you can get a neuroimaging CR. Painful red eyes, well, most of these things ma'am has discussed, like conjunctivitis, keratitis. Then other causes of red painful eye could be presence of a foreign body, either in the conjunctival sac or on the cornea. Scleritis, uveitis, endophthalmitis, a much more severe form of the infection. Then angle closure, acute angle closure glaucoma attack, and of course, trauma. Then pupil size, well, irregular pupil size you will see in case of anterior uveitis, where you see that posterior synechias will develop. And when you dilate such pupil, it will be irregular in shape, and that's called a festoon pupil. When it's acute angle closure glaucoma, you will see a mid-dilated pupil, as you can see in the picture below. Third nerve palsy, well, third nerve is an efferent supply that supplies your pupillary sphincter. And so if there is a damage to the third nerve, it will result in the dilated pupil. Any optic nerve disorders like optic neuritis, AION, PION, it will give rise to RAPD. Okay, so it's important to check for the pupils. Then intraocular pressures. Yes, what are the conditions where it will be elevated? Well, an emergency that the patient will present to you with a raised IOP will be acute angle closure glaucoma. Otherwise, any case of PSEG or POAG, you will have a high IOP. Secondary glaucomas you can see in uveitis, steroid-induced cases, traumatic cases, any large intraorbital tumors or large retrobulbar hematoma can compress on the globe, and because of this mechanical compression can raise the intraocular pressures. Corneal ulcers, well, it has been discussed in detail by Dr. Nupur, so I will not go into the detail, but remember, corneal ulcer is an emergency. The patient will present to you with sudden decrease in vision, pain, redness. You need to do the fluorescein staining, and it could be the bacterial, viral, or fungal. Acanthamoeba, if it's present, is commonly associated with contact lens wear. Fungal is commonly associated with the trauma with a vegetative matter. What are the other signs and symptoms that kind of point towards an emergency? Well, if there's a distorted vision, so distorted vision, so this points towards a macular involvement. So you can give a macular grid to the patient and tell this is what a normal patient will see, and on the side is something where if there's a macular involvement, like in case of a choroidal neovascularization, there will be a distorted image. If there is a sudden onset diplopia, that also becomes an emergency, because the diplopia is, remember, it's the binocular diplopia that we are talking about. That means when the patient is seeing binocularly, he will see double. So in such cases, you should assess the extraocular movements, check for the involvement of the third, fourth, and sixth cranial nerve palsy. Headache can be seen with raised ICT, especially when the patient has associated nausea and vomiting. In such cases, you must check the fundus for the disc edema, especially rule out a papilledema. Well, disc pallor may be seen in certain situations like toxicity, ethambutol toxicity. Well, it's not an ocular emergency, but I'm just touching this topic because so commonly we are treating the tuberculosis patients with ATT, and so commonly we come across the ethambutol toxicity. So even before the vision or the color vision drops in such cases, subclinically you can assess the starting of this toxicity by VER and OCT. So if these two parameters are showing some deterioration, it will be a good idea to consult the pulmonologist to consider stopping ethambutol. So history, what will you take in cases of ocular emergency? Well, you should assess the vision. If it's a vision loss, then what type of vision loss? Whether it's sudden, it's gradual, whether it's unilateral or it's bilateral, whether there is associated pain, redness, diplopia. Look for neurological symptoms like nausea, vomiting, seizures. Assess the visual field. If you do not have a perimetry in your clinic, just do a confrontation test. Then take a history of trauma, any contact lens use, any recent ocular pathology, surgery that has been done, any use of medications. Sometimes systemic illness becomes important. So if you are in your private practice, you should maintain an emergency kit. So emergency kit should comprise of what? Minimum these things should be there, so that you can give some initial symptomatic care to the patient before you refer the patient to the ophthalmologist. So the emergency kit should have eye shield, pressure patch, sterile eye wash, speculum, forceps like Limbs and McPherson, Dismas retractor, a 26 gauge needle, fluorescein strips. Well, a pH indicator or a litmus paper is important in cases of chemical injury. Cotton buds means we are talking about the swab sticks, the bandage contact lens. Then what medication should you keep with yourself? You should have oral analgesics, some Dimox tablets, topical drops like anesthetic drops, proparacaine hydrochloride, artificial tears, topical antibiotics like a ciprofloxacin or a moxifloxacin, cycloplegics like tropicamide, homatropin, and NSAIDs. NSAIDs are non-steroidal anti-inflammatory drops like nepafenac. So just in brief about these patients, when they come to you, what can you do? A chemical burn, you will see during Holi, or a tuna packet injury, commonly seen in our Indian scenario. Remember, alkali burns are much more treacherous and much more debilitating than acid burns. So even before you start examining the patient, you should first give a conjunctival wash. So your first step in this would be give a thorough conjunctival wash, because you have to immediately remove the irritant from the eye. So copious irrigation should be done after giving the anesthetic drop. Put the lid speculum. You can use BSS, balanced salt solution, or if nothing is available, just use a tap water. So for how long should you do this irrigation? Till the pH is neutralized on litmus paper. Then next you can start with taking the history of what was there, what chemical was put, contacts. And now remember that when the patient comes to you, and if there's extensive involvement or extensive chemical burn, then they're raw surfaces. So that can lead to a symblepharon formation, and so the lid can stick to the bulbar conjunctiva. So how can you prevent that from happening? You can either sweep the cornices with a glass rod, or you can put the symblepharon ring. Okay. You have to determine what is the extent of involvement, because that will prognosticate the case in future. So this is the classification system that we use. Roper Hall is a simpler one. Duas is a little much more complex classification. Then you should also check the intraocular pressures in chemical burn cases. And what management do we give here at RP Center? Well, we give this topical sodium citrate 10%, sodium ascorbate 10%. We give this 1 hourly, 2 hourly basis. Antibiotic drops, cycloplegic, steroids, tablet, vitamin C, very important because it will help with the healing. And if it's a very severe involvement, limbal stem cell ischemia, as ma'am was discussing, can have a lot of debilitating complications. So to prevent that, you can do amniotic membrane transplantation. Of course, you would refer the patient for that to the ophthalmologist. Then CRO, a very important medical emergency, which actually you can prevent the vision loss if timely presented, because irreversible vision loss happens after 4 hours of artery occlusion. So what will be the symptoms? Sudden, painless, usually unilateral decrease in vision. What happens since retinal artery is the main artery supplying the retina? Everything becomes pale because your vascular supply is gone. It's only a small reddish spot that you can see at the macula, because at the macula retina is thin, so you can see the choroidal vasculature from there. So this is called a typical cherry red spot appearance. You test for the various, do the blood investigations. Important is do a carotid Doppler, because this artery occlusion is caused either by a thrombus or an embolus. And the source of embolus either could be from the carotid arteries or it could be from the heart. So cardiology evaluation also becomes important. Acutely, how can you manage such cases? Well, immediately try and lower the IOP. What can you do? Anterior chamber paracentesis means you just enter the anterior chamber with the MVR blade, a little aqueous humor comes out, so that will reduce the IOP. Or you can give a digital ocular massage. Another way is that you can try to dislodge the embolus. How can you do it? You give carbon or carbogen inhalation. What does carbon dioxide do? It tends to dilate the arterioles because it causes the vasodilatation. So once the arterioles dilate, it will have a tendency that probably the embolus might dislodge. If nothing is available, just give a paper bag to the patient. Ask the patient to breathe in the paper bag, because when the patient repeatedly breathes in the same bag, CO2 level increases and this might cause vasodilatation. So that's the acute treatment that you can give. And of course, this should be followed by referral to the retina specialist. Blowout fractures. Well, what is a blowout fracture? When there's a direct trauma to the globe, there is increase in intraorbital pressure, and so the decompression happens via the orbital floor fracture. Signs would be this kind of a periorbital swelling, chymosis. There could be limitation of movement if there is an inferior rectus involvement. As you can see in the picture over here, if there's an inferior rectus involvement, the upgaze limitation may be seen. If infraorbital nerve is affected, the patient can have reduced sensations in this area of the cheek and lower lid. So what can you do in the blowout fracture? Ice pack has to be given to reduce the swelling. Well, recovery can be spontaneous if it is minimal. You can give systemic antibiotics like amoxiclav. Basically, it's your amoxicillin and clavulanic acid. And of course, refer the patient for prompt surgery if the diplopia is severe, if there is a severe enophthalmos, or if it's a pediatric patient. Hyphema, well, hyphema can happen in a lot of cases, trauma cases, because of neovascularization of the iris or the angle, or because of traumas, or if the patient is on blood thinners. And if no other cause is identified, do rule out sickle cell anemia, because sometimes sickle cell anemia can cause hyphema. So what do? Measure the hyphema, measure the intraocular pressures, and what medications? Initially, conservative management is given. You give cycloplegics, steroids. If the patient is on blood thinners, stop that. But if the picture is something like this, as you can see in this boy, it's a total hyphema. IOPs are elevated and they cannot be controlled by medical management, then AC paracentesis can be done to drain a little hyphema and lower the intraocular pressures. Next is penetrating trauma. Well, if you see a penetrating trauma, don't try to meddle with the eye. Just stop the examination, put a Catellar shield, a shield something like this, and if possible, give analgesic systemic antibiotics. If NCCT head and orbits can be done, and immediately refer for a surgery to an eye surgeon. Corneal abrasions you can manage. Corneal abrasions are just mild epithelial defects that is happening, but the patient is very symptomatic because it's the cornea that is affected. So you assess what is the extent of corneal abrasion by a fluorescein staining that Dr. Nupur has already discussed how it is done. So, and how do you manage a corneal abrasion? Just give a patching, overnight patching. And of course, it should be followed by topical antibiotics, cycloplegics, and NSAIDs. If it's a foreign body, symptoms are similar. It's like pain, irritation, redness. So if it's a corneal foreign body, you might have to remove it with the help of 26 gauge needle or using a McPherson forceps. But if it's a conjunctival foreign body, how will you examine it? You might have to do a double lid eversion with Desmar's retractor, because many a times a simple lid eversion will not reveal it. So double lid eversion is what is shown in this photograph. You do that and give an extensive copious irrigation, and irrigation similar to what has been described in chemical injuries. And later you can give you can patch the eye, give antibiotics, and of course steroids can be given. Retinal detachment, when will you suspect? If there are flashes, floaters, decrease in vision, patient complains that some kind of curtain is falling in the eye. Why? Because retina, it's the area of the detached retina. The causes are trauma, myopia, or posterior vitreous detachment. If you can do a dilated fundus examination, do it. Otherwise, immediately refer to retina person. Angle closure glaucoma, patient will present with a picture something like this, as you can see in the upper image. Painful red eye, will have blurring of vision, colored halos. On examination, you will see that AC is totally shallow, cornea is edematous, there is redness all around. If you can measure the IOP with applanation, do it. If not, then just digitally assess it and compare it with the fellow eye. You can assess that the eye is stony hard. So this tells you that IOP is extremely high. Pupils will be mid dilated. So how do you manage? We give IV mannitol, 20% mannitol, 250 to 300 ml fast IV injection has to be given. Next, you give oral Dimox, 250 to 500 mg, 2 to 4 tablets per day. Then topical anti-glaucoma medications, and the definitive treatment is once it is taken care of, the pressures have been brought under control, corneal edema has resolved, you have to do a peripheral iridotomy, for which you will refer the patient to the ophthalmologist. Remember the side effects of Dimox, because if you're prescribing it, patient can have metallic taste, GI upset, paresthesias, and of course electrolyte imbalance. Corneal ulcer, the management has already been, the examination and management has been discussed by Dr. Nupur already. But just remember that we give fortified antibiotics if there is a large central ulcer. Fortified antibiotics are not available commercially, so it has to be prepared using injections. So I drop cefazoline, I drop vancomycin 1%, or I drop tobramycin 1.3%. We prepare it here at a pharmacy, and that is given 1 to 2 hourly basis. If it is fungal, you give topical natamycin 5%, amphotericin B or voriconazole 1%. If it is viral, we give eye ointment acyclovir 3%, depending on, and the frequency actually varies depending on how severe the infection is. Optic neuritis, well, the patient will present with unilateral acute loss of vision. Typically, they are young females, and they have a very typical history. The vision deteriorates in the initial 1 to 2 weeks, stabilizes, and then spontaneous improvement starts after that. So that is a case of typical optic neuritis. You might not do anything for typical optic neuritis because spontaneous recovery will happen. But just to hasten the recovery, we give an intravenous methylprednisolone 3 to 5 days, for 3 to 5 days, followed by oral steroids. But before that, you should assess what type of optic neuritis it is. It could be optic nerve head swelling, that is papillitis. It could be retrobulbar neuritis, where the optic nerve head appears to be absolutely normal, and or it could be neuroretinitis. But remember, in any scenario, optic neuritis will have a RAPD definitely. Then field effects could be enlargement of blind spot as seen in the visual field here. It could be altitudinal scotoma or a central scotoma. Contrast enhanced MRI of the brain and orbits is definitely indicated to confirm the inflammation in the orbit, and secondly, to rule out multiple sclerosis. So just I would like to conclude that as an optometrist, you actually form important pillars of primary eye care. So you, in cases of ocular emergency, you will be the first point of contact. So by doing a quick diagnosis and by doing initial baseline investigations, you can do a quick referral to the relevant ophthalmologist, and it will also help you in developing your skills better, and also, improve your practice, private practice. Thank you. So I think I'm done. So
Thank you so much, ma'am, for such an informative talk and advice. We are highly obliged. Audience is requested to send the queries in the chat box.
But Darshita, I realized, there are no audiences at all.
No, ma'am. Actually, it's the privacy that you cannot see the audience.
Okay. It's that way. Otherwise, I thought,
Yes,
they
ma'am.
must type.
Yeah,
But
500 plus people connected with us.
okay, so just ask them if they have any query, because ocular emergency is something you will see in your day-to-day practice. And if you do anything wrong in that, it could be visually threatening to the patient,
Yes, ma'am.
So I think it should be an interactive session. They should definitely ask questions.
The delegates are requested to please send their queries in the chat box.
Otherwise, I would think that my presentation has been so crystal clear that they do not need any clarifications.
Yes, ma'am.
So either way, I'm happy, but I think you should have some queries and questions. So, okay, thank you. Are there any questions?
Yes, ma'am, we have received a query in the cases of acid and alkali burns.
Yes.
Please re-explain the management.
Yeah. That's a
in
very
PEC especially.
Sorry?
In primary eye care setup, please
Yes,
explain
yes,
the
yes.
management once again.
Yeah. Chemical burn actually is a very important topic. And, in India, because we have so many festivals, so one is the holy thing that always, you will see the rush of patients. And secondly, these tuna packet injury have been very specifically described. Why so? Because these tuna packets are available in very thin, flimsy polythene packets. So the kids, when they are playing with this, they tend to press it, and suddenly the packet, tends to burst, and it causes a tuna packet injury. So this alkali injury is quite debilitating, very treacherous. So what you have to do is that even before you start the examination, a patient comes to you, tells you, "Ki aise, this has happened. The chemical burn has happened with some sort of a chemical." And most of the cases, they also bring the chemical along with you, the bottle or whatever. So before you do any examination, first you should give a conjunctival wash. Why? Because you should not waste the time in examining, because the longer the chemical is in contact with the ocular surface, the more it will damage your limbal stem cells. So it's very important that you first give a thorough conjunctival wash. So how will you give a thorough conjunctival wash? For the thorough conjunctival wash, you have to give a copious irrigation. So copious irrigation you can give, first just put a lit speculum on the eye, then put the anesthetic eye drop, and ideally you should use a balanced salt solution. If nothing is available, then you can use a tap water. So simply pour lots of tap water into the eye so that it washes off any chemical which is there. In the fornices, you should, avoid the fornices, do the wash thoroughly, and you should do this till the point you should have a litmus paper ideally with you, or a pH testing paper, any pH testing paper. So you keep on checking, after giving the wash, again you check with a litmus paper. So the pH should become neutral, because the pH of ocular surface is somewhere around the neutral side, 7 point something or this way. So it should come on to that value, because with the color change you can assess the pH, the change of the pH in the ocular surface. So once you have, if you feel that the pH is still not neutralized, continue giving the wash. So after you have neutralized the pH, you have given a thorough wash, then you start asking questions, and then you start examining the eye. And another thing that you should do is removing the sweeping. Basically, when two raw surfaces, the bulbar and palpebral conjunctiva, when they are raw means the epithelium is abraded. So when they will come in contact with each other, what will happen is they will form symblephron. The eyelids will stick. So that has to be prevented, because Dr. Nupur showed some of the photographs where you could see that everything, is stuck. So that is what happens in chemical injury. How can you prevent it? You sweep the fornices with a glass rod. Means you have to sweep everywhere here. So if any adhesions are forming, they will break down. Otherwise, better you put a symblephron ring. So this ring is placed in the ocular surface. So this just exposes the corneal area, and rest of the ocular surface is covered with this ring. So it prevents a direct contact of the two surfaces. And next, then you would would determine what is the area of involvement that can be done with a slit lamp examination. So limbal involvement, Dr. Nupur showed you very beautifully those limbal stem cells. So in chemical burn, those limbal stem cells are damaged, and instead of that little pigmentation that you see for the limbal stem cells, you would see the whitening of the limbal area. And also you can assess the conjunctival involvement by appropriate staining, either fluorescein or a rose bengal staining. So depending on what is the cause of involvement, you will grade the ocular surface burns. You must check the IOP, because shrinkage of the tissue happens in chemical injury, and that can suddenly lead to rise in IOP. And medically, at least you can start some of these drops, that is sodium citrate 10%, sodium ascorbate 10%, antibiotics like a ciprofloxacin or moxifloxacin, cycloplegics like HA, homatropin, steroid, mild steroids have to be given to prevent scarring. Vitamin C tablets also help in the recovery and healing, and therefore vitamin C tablets are started around 2 to 3 times a day. And if it is very severe, the patient should be referred for amniotic membrane transplantation, because AMT, if it is given on time, it can restore your limbal stem cells and restore your ocular surface. Is that clear?
Yes, ma'am. We have one more question.
Yes.
How do we differentiate between acid and alkaline chemical burn if the patient is unable to describe the chemical and we do not have the litmus paper too?
Yeah, then it gets a little difficult. It gets a little difficult. However, the management is not gonna change. You need to understand it's only on the basically on the basis of acid and alkali. The differentiation helps you in understanding that how severe the involvement can be. Remember, alkali injuries will cause much more severe involvement. Okay, so it will not, however, affect the management that you give. The management will remain the same. So even if you do not have a litmus paper or a pH neutralization paper, at least give a thorough wash from your side. If you have to give it for 10 minutes, 15 minutes, do it. Okay, it will not affect your management, even if you're not able to guess what the chemical was. All right, anything else?
So, ma'am, does that mean that we have to irrigate in both the cases, no matter if it is an alkali injury or an acid injury?
Absolutely. Any chemical irrigation, the irritant has to be removed from the ocular surface.
Okay, ma'am.
Yeah.
We have another question for Dr. Nupur Gupta. How do we manage a patient who has developed corneal opacity due to dry eye? Over to you, ma'am.
Okay, just to add on the chemical injury part, one thing is that you do irrigate all the cases, and if you examine on slit lamp, you are able to find out whether it's a acid injury or a chemical injury or an alkali injury, because you can see the depth of penetration. That is theoretical, but we know that acids do not go deeper and alkali go deeper. But definitely, as Rebecca said and very beautifully presented, that you have to irrigate and manage. Each of them have a similar manifestation. There will be an epithelial defect, there could be a raised IOP, there will be limbal stem cell loss. So it's a similar thing. For the corneal opacification in patients with dry eye disease, see, you have to see what is the cause of dry eye disease. The ocular surface may not be healthy in a case of trachoma, so you have to manage accordingly. So in an acute setting, where you have a limbal stem cell deficiency and corneal opacification, you have to take care of the active inflammation. So if there is, suppose, a Steven Johnson minor and you have corneal opacification occurring, you have to give the dry eye management like lubricants and maybe cyclosporin. But along with that, you will have to give low potency steroids to actually decrease the inflammation. And then you take in, if there is a limbal stem cell deficiency where you've seen, then the patient has to be taken up for a limbal stem cell transplant. So that depends on whether the other eye is normal, not, and has enough stem cells to transplant from the other eye, or otherwise you can take it from the mucous membrane, the oral mucosa. We have different setups. So that anyways has to be referred to the ophthalmologist. The other corneal opacification that occurs due to dry eye disease depends on which disease setting it is occurring. So then when the limbal stem cell deficiency is taken care of, you most likely you will have an anterior corneal opacity. So that is taken care of a lamellar keratoplasty like an ALTK, or a superficial anterior lamellar keratoplasty, which can be the donor graft will be secured with glue or with sutures. So it depends on what is the thickness of involvement with the corneal opacification. Dry eye disease, it usually involves only the superficial layers and the anterior stroma. Am I clear, or you wanted to ask something else?
Yes, ma'am, that was great. We have another question too, that will the management change for both the different types of foreign bodies?
Yeah, basically, not essentially. It depends where the foreign body is. It's more like that. So if it's like a metallic foreign body, or if it's a wooden foreign body, mostly it's a metallic foreign body which tends to, and also a metallic foreign body tends to go a little deeper, because they usually high velocity projectile objects. That's how you get the metallic foreign bodies. Wooden foreign objects are mostly superficial, but sometimes it might go up to the even enter into the anterior chamber at times. But removal has to be done in any case. But difference is, in cases of glass foreign bodies, or in cases of blast injury, what happens is that there are multiple small minute foreign bodies, so you might not be able to remove every bit of it. So if you feel that whatever foreign body you are able to remove easily, that should be removed. And many of the inert foreign bodies, like in cases of blast injury or a glass foreign body, multiple small shattered glasses, so that probably can be left if you feel that it's difficult to access. Because what happens in like firecracker injuries or blast injuries, it is very difficult to remove every bit or every point of the tissue, because it's multiple, several foreign bodies scattered over the cornea. So you just remove the bigger ones and might just leave the smaller ones in situ, and follow up such cases, that what is happening over a period of time. Okay.
Doesn't the left foreign body are a risk to the ocular surfaces?
Ocular surface basically depends, that's why we're saying you have to like in cases of blast injury, you might have little gunpowder, or pellet, it's particles of the pellet and all. So you have to observe over a period of time. It might remain the same, it might cause a little pigmentation around it, but it might not, if it's very small, you're unable to remove it. So for all practical purposes, we don't remove, especially blast and firecracker injuries. You are unable to remove those minute foreign bodies. So whatever the bigger ones, we can remove it. You have to follow them up, and many a times they remain in the cornea, they remain inert. But whenever you see that something is happening on follow up, then of course you might have to maybe perform then some other complicated procedures to remove it. And but usually it's so minute that you cannot pinpoint and pick them up. That's the problem.
So does the depth of penetration changes the treatment or the management?
Yeah, depth of penetration also matters. Like if a foreign body is deeply embedded, you still try to, and if the epithelium is kind of grown over it, and you feel it is not a vegetative matter, then you can, and it's somewhere in the periphery of the cornea, and epithelium is kind of grown over it. It's very nicely in the corneal stroma or deeper in it, you can probably follow up. But it is something in the visual axis, or if it's a vegetative matter, should definitely be removed.
Does the vegetative foreign body also causes a risk of endophthalmitis?
Yeah. Vegetative foreign bodies especially are responsible for infections, ulcerations, endophthalmitis. And it is because vegetative foreign matter is associated with, it is usually contaminated with the soil. And so chances of infection are much more higher. So you need to treat them with antibiotics as well. Systemic antibiotics also have to be given. It has to be removed. In fact, intracameral antibiotics are also given at the time of removal. So is this point clear?
Yes, ma'am. Thank you so much, ma'am. So we do not have any more queries. I think we are concluding the session. Thank you so much, ma'am. Thank you, Nupur ma'am, for being with us and supporting us in such tough times.
Thank you, ma'am. Thank you so much. It was a nice interactive session. Thank you, ma'am.
Thank you, Rebecca. You were good.
Bye, ma'am.
So we are concluding the day today You all will receive the 30 days access to all the lectures. Please join us tomorrow right at 10 a.m. in the morning. We'll be right back. Thank you guys. Thank you everybody.